Hello, friends. Today is the 26th of September 2024. We are going to celebrate the Contraception Day. This is a World Contraception Day. Today, we have a theme the choice for all and freedom to plan and power to choose. The greetings from FOGSI Family Welfare Committee, myself, Dr. Ashish Kale. Today, we are going to have something new, which is called as a contraception mandate, as a webinar series, which is going to be displayed on the Facebook page of a FOGSI. I am very privileged to have all of you on this particular day because the contraception plays an important role. All of us know that India is a populous country. And being a populous country, we know that we have an adolescent age group, which is a much more in our uh, country. For this, we have to achieve the total fertility rate below a 2. And there are the certain policies by the government of India we are rolling in. We do have different things to apply on. We have a long acting reversible contraceptions. We have a short acting reversible contraception. And today we are going to tell to all of you what is a being it is a contraception mandate, and this is going to be a webinar which is going to take place for 12 to 16 hours, and all of us are going to share our knowledge on different contraception uses. And as a gynecologist, all of us will be interested in listening to all the our eminent faculties. At the outset, I'm really thankful to all the faculties who have taken their precious time from their busy schedule to make this presentation and available to all of us. I'm also thankful to this uh, coordinator of this particular contraception mandate, Dr. Priya, Dr. Avir, Dr. Konar, and Dr. Ashwini, for making this happening for last 12 hours to enjoy. This is a continuous webinar which is going to take place for 12 hours. My friends, it is my earnest request to all of us that even if you have a certain problems or certain needs to be clarified, you can put up your questions. We'll get back to you. Being this is a webinar, this is going to be a full depth and of a knowledge about everything from the history to the modern aspects of the contraception. What is the POCs? That is a progesterone only contraception pills, maybe implants. We are taking all things in details. It's my privilege to again show it to you what are the activities what we had done. The activities what we are done from the year 2023, I am going to showcase to all of you. Being the FOGSI has taken over as a chair of this FOGSI Family Welfare Committee, I had taken the chair in 2023 under the leadership of Dr. Rushikesh Pai, who is my mentor and my teacher. All of you know that being the FOGSI is all the platform which has our given to my, but it is not me. It is the team that matters, and I have a beautiful team to work on. There is the first thing that comes to for installation is which has happened in Calcutta by in 2023, wherein I taken this of a leadership from my previous chair, Dr. Shobha Gudi. With the presence of, you can see there are the eminent faculties who are present in the Calcutta at that time. The year started in 2023 under the leadership of Rushikesh Pai sir and the Secretary General of Dr. Madhuri Patel madam. We had done a different armamentariums. We have three arms. One is a publication, then second is a national and international events. Third is the social and academic activities. All of us knows that we this is a biggest what do you call a segment of our uh, knowledge that the contraception biggest important role in the woman's life, and that's why the social and academic activities plays an important role. To say some few publications, we come up with the book of a modern approach to the contraception. We come up with the GCPR, that is a long-acting reversible contraception, which is available at the FOGSI site. All of us can see and visit that. Secondly, we come up with some new advantages of AI. The AI, we know that AI comes in a different techniques. We used AI in a different our practices, our different surgical aspects, but the AI do have its role as far as the contraception is also considered. The AI, we generated the AI app tool, and which is well taken by the FIGO committee under the leadership of Aparna Sridhar. She appreciates our efforts of this having the AI generated app, and which is going to be along with the collaboration with the FIGO. We are launching it again in the FIGO as well as in the FOGSI for a larger time. We come up with the advocacy with the different associations. Like I had gone to the Kenya to learn the implants, how the implants are inserted and the removal of the implants. And the same thing is advocated by the FOXY. We had done more than 100 live workshop. The TOT programs has more than 30, and which is all accepted by the different societies of the FOXY. The FOXY is a strength of a president and secretaries of each societies, and I believe that if the societies and the secretaries of the societies come up with us for this particular training activities, we are there to train more and more TOT programs in future also. We had an opportunity under the leadership of Dr. Jaideep Tang sir. Now he is a president of a FOXY. We had visited Nepal in for FP 2030, accelerating the access to the postpartum and post-abortal family planning workshop under the guidance of USAID. Dr. Jaideep sir, who was that time the president-elect, has discussed the role of the private sector in strengthening these programs for the governments of India, and he has given the importance and here to the private sector, because the public sector usually they talk about their only studies and their work done, but he insisted that the private sector also plays the important role, and that is well taken in that meeting. The other training activities what we had done in 2023 is implant trainings in Orissa, Gujarat, Tamil Nadu, and Rajasthan. The subcutaneous Antra, which is coming up, we are going to have a more scale-up model for the same. The family planning methods orientations for the doctors, nurses in the tree gardens of Assam is well taken program. The physical workshop we had done in a different states. We had done in Orissa, we had done in Calcutta, we had done in a city of Kota, and that is going to be a continuations with the same. The first Physical Family Welfare Committee workshop in association with the JAPIGO occurred in 24th of March 2023, which has a Star Global Summit in high risk pregnancy in city of Pune. The MTP committee, along with the FOXI Family Welfare Committee, we have conducted MVA and employment workshop as AOGD conference in Gurugram. And in September 2026, we have the workshop at Lucknow. These are the few glimpses of that, which is under the leadership of that time. It was of my VP in charge, Yashudhara Pradeep Madam. Again, the workshop on the contraception and reproductive health and menstrual health, the convener at that time was a Surbi Singh, and who you can see this is well taken in the city of a Sikkim. So we had gone to the east, northeast, we had gone to the west, we had gone to the south and north. So in 2023, the FOXI Family Welfare Committee is successfully accomplished the goal of a World Contraception Day. That time we had done along with the association with the JAPIGO, FIGO, and Ministry of Health. Approximately 19 physical activities are being done in different parts of India. There are the three virtual platforms wherein we done a national webinars. The power of options are there. Then the Gunj, which comes as a which has gone to the worldwide nation worldwide, and the proud to be highlighted that in a different parts of the country we had done in the same day as a World Contraception Day on 26th of September. That is the last year. The highlights of this is you can see these are the highlights of the World Contraception Day. You can see the webinars which is going there and which are being addressed in different parts of the city as well. The Gunj, the power options, awareness regarding the power of a contraception on the World Contraception Day. There are the esteemed leaders in their field. They had given their messages and which is well taken by the audience that time. The activities pan India on the World Contraception Day. You can see the different things which we had done in the social activities. We had done the workshops. We had done the webinars for our own gynecologist. But the majority of the things has been done on the ground, and that is the social activities. You can see the glimpse of it. The social activities, why it is important? Because it's a direct touch to our community, and the community at large going to get benefited by our activities by the FOGSI itself. The slogan of the competitions we had done the 26th of September, the World Contraception Day, the FOGSI Family Welfare Committee has announced the slogan competitions. We had the entries of more than 20. The first prize goes to the Faridabad Society for the maximum participation, and the first and second prize goes to the Kota Society, and the third member is from the Faridabad Society. We had awarded them on the same day. The nine webinars are the glimpse of it. We can see the lectures, panel discussion, recent advances in the field of contraception. There are the debates and the experts' opinions from the stalwarts. You can see the few glimpse of the same. The glimpse of the educational webinars, which was ongoing activity on that day, that's the last day. And today, as a World Contraception Mandate, we are doing the same again. The one of the record and one of the unique activity from the Family Welfare Committee, that this is the webinar which is going to be there for next 12 hours to run. So this is the ongoing webinar, and this is the maximum webinar time what we can have on our proxy platform to see for all the gynecologists to attend and enjoy the feast of the academics. Here again, you can see the online webinar. The same, the webinars are have been arranged in the societies like the Faridabad, Aurangabad, Kota, Delhi, Gujarat, Uttar Pradesh, Punjab, Haryana, Himachal Pradesh, Jammu and Kashmir on the same day, and which has been well taken in a different societies. As I believe there are the societies president and secretaries are the important part of the FOGSI, because every implementations taken place in the FOGSI is because of the efforts of them. So we had make them a part of our society, of our committee, and we had done these many programs and webinars with all of them. The social activities, we had done the public forums 47, physical CM is 8, free contraception camps for those are underprivileged areas across the countries are 6, and these are the are where our each members of my committee has gone there and contribute from their side. These are the particularly extensive coverage, because once we are done, we need to publish it and we need to document it, and that's why our committee members had done it. This is well taken by the print media across the India. These are the few glimpse of it. We can see the FM also. We gone, our one of the committee member has gone to the FM and talked to us, talked to all of them. One of the committee member has gone to the Facebook live and talked about the Myrina hormonal contraceptive, and these are the few glimpse of the same. The projects, definitely as a FOGSI Family Welfare Committee, we have the projects of the two. You can see the project Pragati, that is adolescent contraceptive awareness, and another is for the urban and PSC healthcare centers. These are the CMEs, which is the physical CMEs what we had attended, and we had gone physically there at the Ujjain, maybe at the Gwalior, Latur, and Kims Bhubaneswar, and there are the many glimpses of it. The same webinar is continued with the different societies. We had taken the societies from the tier 2 and tier 3 cities, and you can see the reports of the same. The glimpse of the CMEs, which are the physical CMEs, which have been done with the different societies of the FOGSI. The public forum education and awareness activities, these are the I think a backbone of my committee, because the committee activities for the gynecologist is ongoing with the different committees also. But when we are going to the public make a noise, and they are the now our theme is also the choice of the woman. So it is better to go to the population at large and talk to them what is their choices and what is their acceptance things. The glimpse of the public activities are the same. You can see the many of them. Now the again the program starts with the new leadership under the leader of Dr. Jaideep Tang sir. Are the his vision for this particular committee is very large, and he is the instrumental in my progress in the different organizations like a WHO or maybe USAIDA or maybe a USFDI. Being a instrumental as a my uh, a guru, my mentor, has introduced me to the large organizations at the worldwide, and I am really indebted to him for his guidance throughout my this year. So, family welfare committee activities, again, we come up with the social activities and academic activities. and the publications. This is the logo of our president, FOGSI, Dr. Jaydeep Tang sir. You can see this is a 360 degree approach to the women's health, and the same thing we followed in our committee. We have holistic approach, and as far as the contraception services are considered. So online education webinars up till date is 29, and these are the few glimpse of it. We do a Gunj program. This is the Gunj continues Jnanavardhak as a Jnanavardhak Budhwar. So Jnanavardhak Budhwar is going to be there, and this is an ongoing activity, and you are will be going to evident it for next few months in a series also. Always there is an inspirational talk from our stalwarts in the FOGSI, like the FOGSI president himself, my Secretary General, Dr. Madhuri Patel Madam, and VP in charge, Dr. Neerja Madam. So always they are whenever they are busy, also they make it a point that they come down to this particular number, the Budhwar, and they share their knowledge to all of us about and also encourage us to talk more about the contraception services and the private sector contribution to the different level. These are the few glimpses wherein we do this Gunj program, and we always happy to associate with the different activities of the FOGSI and different committees also. You can see the same things which is going on with the every Wednesday or every last Wednesday of our month we do it, and these are the few committees wherein we take the committees along with us, along with the different societies also. Like you can see a Kasoga society, or maybe there is a food, drug and medical surgical equipment committee of the FOGSI. So always we have a liaisons with the different committees, as because we are as a FOGSians, so we always found out with the other committees to have our work to be showcased on. So the FOGSI family committee, along with the Young Talent Promotion Committee, we celebrated the International Women's Day with the theme of the role of contraception in a woman empowerment on 8th of March 2024. These are the international on the International Women's Day. We received 56 slogans, 26 poster entries. All the participants had received the certificates from our side, and there was the judge. I should be naming them. Dr. Yelikar, Dr. Leela Vyas, and Dr. Charmala was the judge for the same. Without them, because it's a very easy to get the entries, but we need to have that much of judging power and the judge who are apt to give their inputs for the same. The webinar in association with the other FOGSI committees goes on. We have the Ranchi OBGY Society. We do it with the FOGSI Family Planning Committee, with our own as a OBGY 360 degree, with the quiz committee. We have public awareness committee. We have an association with all those committees, and you can see the pamphlets and the talks which has been given by my family welfare committee members. Family Welfare Committee celebrates Safe Motherhood Day in association with the Practical OBGYN Committee, along with the Safe Motherhood and Young Talent Promotion and Endocrinological Public Awareness Committee and the Ethics Medical Legal Committee on 11th of April 2024. These are the particular glimpse of the same. We celebrated the World's Population Day on 11th of July 2024, and these are the glimpse, because what I feel in 11th of July, I attended the meeting of with the GOI with our cabinet minister, JP Nadda ji, who also told us that it is a public sector is done the job, and private sector is also doing the job, and which is appreciated by the cabinet minister, which is really a good gesture from them, that they are appreciating the FOGSI as a one of the private sector, and I also appreciate the work done by my committee. The secondly, what he narrates in his talk, that it is always that we talked about a total fertility rate, and we are achieved it. Though we are a populous country, we know that it is achievable goal, and this achievable goal is already been achieved in 31 states of our country, and we are marching towards our success. So it is not just that the people are talking about we are populous country, we are doing it, and all this credit goes to all FOGSians and all FOGSI president and secretaries and office bearers for that matter. We done these activities. You can name. We have the deepest gratitude to distinguished faculties like Dr. Jaideep Tang sir, President of FOGSI, Dr. Madhuri Patel, Secretary General of FOGSI, Nirja Batla, for giving their inputs in this particular day of what we celebrated on 11th of July. These are the webinar glimpse wherein we can see there is a SAFOC president who was present that time, had given his inputs on the same. These are the glimpse of the webinar we had done on the 11th of July. We even of July we have a journey of contraception in India. The future is a choice, and which, as you can see, there are the topmost speakers. Dr. Raj Kumar, he is the deputy director of MOH from the Karnataka. We get a different government officials for this, because being just a FOGSI is a private sector. We need to have hands in hand with the government authorities also. So we make this point that on the 11th of July we should have the government people coming down to us and talking with us on the same platform. So these are well taken, and these are the different government officials are talked to on that particular webinar, and which is well taken by the all. On 8th of May, we also had with the FOGSI Food and Drug Committee, we done a symbiosis series, and these are the glimpse of the same. So on 19th of July, again with the Association of Madhya Pradesh OBGYN Society on the World Population Day, on 19th July we had the webinar, and we can see the glimpse of the same. On 25th we have with the Bangalore OBGYN Society. On 31st of July, it is again the Gyanvardhak Budhwar. What I said about it, it's a every month activity, and we are still doing it. And I'm really thankful to our president, Dr. Jaideep sir, for allowing us to do it in a larger side. And these are the particular glimpse of the same. On 14th August, again, we had done this particular Gunj program. On 28th of August, where the webinar has taken place with the DMPSC. And you can see the in the DMPSC, this is one of the things which has come up with the idea of the government of India. They are much more now targeting as a LARC methods like implants, and these are the subcutaneous DMP. And now with the leadership of Dr. Jaideep Tang sir, we have come up with the DMPA a statement, that is a policy statement from our side, and which is going to put up into the FOGSI website. So what I request all of you to just go through it, and you will be able to understand what it means to all of us in order to give these services to a large population. On 13th of August, in Pune, we done a webinar with the like a cutting edge webinar, and these are the prominent faculties for that. So 18th of August, again, there is a NAMA, with association of a NAMA, that is a NAMA, which is again the organization. So as a family welfare committee, we always has a different association with the different people. So it means that it's usually better to listen from the others and adopted some policies and some good points from the other association also. And that's why we are privileged to have association with many. On 20th of August, again, we talked about the artificial intelligence, and I'm really thankful to Dr. Avir that he come up with the idea of AI in a contraception app, and which is well taken now with the POGS, that is a Pune OBGYN Society. We had a webinar on just on AI and what AI can do in as far as the contraception is considered. And these are the few glimpses of the same. And the reports, the ministry meeting, and the publications, whatever we had done in 2024. I will not take much time, but these are the certain things what we gone into the managing committee. Last year, I presented my report that time, and under the leadership of that time with the FOGSI president, Dr. H.D. Pai sir, we had done all this activity, and it is a showcased in a Kolkata meeting in the FOGSI meeting that time. These are the 11th of July, wherein virtually we attended the meeting with the government of India, with the cabinet minister of JP Nadda ji, and we had done that. The efforts of the private sector is been taken into account, and I'm really appreciate that the government of India is recognizing us as a public private sector at a large, and then come up with the PAHEL, the overview of contraception what we launch this we release this book of overview of contraception on 20th of April, that is at Calcutta, and this is our own publication, and all of you can have a glimpse of it. The Family Welfare Committee, the FOGSI workshop in association with Jabalpur. This is the physical workshop what we had done, and we have also released there the from the Jabalpur OBGY Chota Parivar Sukhi Parivar. This is just a booklet, and this is a GOGS bulletin. The Mimansa dedicated to the contraception articles by different members of us. You can see the articles which has been released there. The 11th day is the publications what we had done from India. You can see, you will find the action plans that the Indian delegations created on the page 2024. The action plan identifies the several key priorities to scale up the PPFP and PAFP programs, and that is along with the statement of AP 2030. The another feather in our cap that this is the milestone where we are in amalgamation with the AP 2030 visions. We are doing it, and you can see here the users by our country is the highest one of this particular statement, what the policy statement which has been documented that time. Again, the publications in the AOGD bulletin, we had done the publications along with the AVS Sarkar and myself. This is the publication copy in AOGD bulletin, and this is work done as far as the publication is considered. The other training activities in 2024 we had done on 18th of May. I believe our we are safe because we our boundaries are guarded by our soldiers, and I'm very much privileged that I had gone to FMC, that is Armed Medical Forces, Armed Force Medical College, wherein we done the TOT programs, and 30 delegates are been benefited by the TOTs of the implants. Again, the implant training has been done under Dr. Preeti Bhurtania. She was one of my committee members, and will appreciated her help in that particular venture that time. The health checkups and the camps, we had done a total 40 such activities conducted in our year. We had done a free camps for all public awareness as far as the contraception is considered. We also done the much more activities in the schools, and these are the few glimpses for the same. And these are the activities what our family planning services members are doing it. As the committee members, they had done an excellent job in a different set of practices. The healthcare checkups, camps, and awareness activities is ongoing. On 3rd September, we had done also on air Akashvani Kota, one of my family committee member. She had done it on air, the Akashvani where she has talked about the role of contraception in prevention of maternal and the female malnutrition. And this is the few glimpses of the same. The workshops and the conference attendance. This is the, I will not go into the details. This is our Jabalpur and our Burla's OBGYN Society at Orissa. These are the glimpse of the same. This was the physical conference on the contraception. On 16th of June, the FOGSI Food and Drug Medico Surgical Committee. This was national conference, and the few members has attended the same and delivered their delegation. The workshop on population stabilization meeting, Unmeet the Need, on Jabalpur. This is already been documented, and we had gone there on 30th of June, which has taken place, and the 80 delegates attended the same. Yeah, these are the few glimpses of the same. On the 17th of August, it was a BIT con Jaipur, and which is one of my committee member, Dr. Avir, had gone there, and he talked on Risuk. And these are the few photographs of the activity. On 18th, it was a national conference is held, and the speaker was Dr. Priya Gupta. She talked on a concurrent need of contraception, and these are the particular glimpse of the same. On 31st of August, Dr. Neha Varun, she had gone with the MTP Con, which has held just now 1 month prior at Latur, and she was physically present there, and she presented our committee, and she talked about her lecture there at MTP Con Latur. On 11th of July, again, these are the first particular things, and this is how what is my committee is doing. And I'm really I'm just a face. I again said to all of us that it's a just a tenure of 3 years. The much more work has to be done, much more steps has to be worked on. It's a group that makes an effort rather than a single man. I'm really thankful to all my committee members, all my national coordinators, and the uh, zonal coordinators to take this particular initiative. And I'm really thankful today that all of us are going to listen to all the experts of this field and to make it a large success. Thank you. Thank you for patience hearing.
Good morning to all. My topic is adolescent contraception. See some facts about adolescent. Adolescents have the lower level of contraceptive knowledge and use. 60% of the female had sexual intercourse by the age of 18 years and 80% by the age of 20 years. Median age of first intercourse is around 17 years. Some adolescents, they have even more than one partner. So the fact sheet, the adolescent pregnancies in LMICS is 21 million birth per year as on 2019. Among these pregnancies in adolescent, 50% are unintended and 55% of the unintended pregnancy end up in abortions. So what are all the importance of contraceptive awareness? As all of us know, this September 26th is the World Contraception Day. So the importance of contraceptive awareness among adolescents is very, very less. So if they don't have the contraceptive awareness, they end up with the teenage pregnancies. What complications can happen in the teenage pregnancy? Most of the time, the anemia is the common complications with the teenage pregnancy. So when a girl is 12 years, the hemoglobin should be 12 grams. If it is not corrected in that age, with the low hemoglobin, they will become pregnant and they will end up in the teenage pregnancy where maternal mortality is directly or indirectly 50% is due to anemia. So the common complication is anemia and they may end up with the blood transfusions and the preterm birth, hypertensive disorder, which can go to preeclampsia and eclampsia. And the pelvis, it may not have grown completely and they can lead up in the cephalopelvic disproportion, and which can also lead to the obstructive labor, postpartum fistula, puerperal endometritis, and there is increased incidence of cesarean section also, chlamydial and gonococcal infections. These are all the complications of the maternal complications with the teenage pregnancy. With the neonates, again, due to the anemia and the HDP, hypertensive disorder, they can be the low birth weight and congenital birth defects can also be present. Preterm birth is present. And the neonatal, once they are delivered, the upcar will be more than very less within the 5 minutes. And they can also even go for the intrauterine death also. So the baby delivered by the teenage pregnancies may go for assisted ventilation requirements. They may not be in a position to feed the baby also. Again, the lactation will not be sufficient for the baby delivered by the teenage pregnancies. Why the teenage pregnancy rate is increased nowadays? This is common even with the rural and the urban area. The common causes which we think is early dating behavior, the behavior of the teenage girls, that is the early dating, and they are not following the contraceptive methods, and the high risk of smoking, alcohol, and the substance abuse, and the peer pressure, that is the support group of the few friends. Whenever the adolescent girls, when they have the doubt, they don't come and have the opinion of the parents or the teachers. They have the opinions only with the peer pressure. So the peer pressures to engage in the sexual activities, which leads to the teenage pregnancy. Once they become teenage pregnancy, what happens? Stress and depression. And before that, even when the exams, when there is a failures, they go for stress and depression. And this stress and depression again is a cause for teenage pregnancy. And because of this teenage pregnancy, they again go for the stress and depression. This is a recycle. And the criminal behaviors, abuse, sexual abuse, that leads to the rape. This is also one of the causes for the teenage pregnancy. and living in a community where early childbearing is common and viewed as a normal rather than a cause of concern. Because in the rural area, they may not have money to give education to the younger people. And the early menarche, they get early marriage. And because of this early marriage, they go for the teenage pregnancy. And the partner, they may be aware of the contraceptive methods, but this teenage girl will not be aware of the contraceptive methods and they don't know to postpone the baby and end up with the teenage pregnancies. What are all the barriers to use the contraceptive in the age that is adolescent age, 10 to 19 years? That is mainly the lack of awareness. They don't know, some girls, they don't know what is contraception and where it is available, how to get the contraceptions, and the existing myth and fear. Suppose the girl, she cannot go and tell her parents that I had a boyfriend, I have become a pregnant, where to go for the MTP. So most of the time they come for MTP with the friends only. So the existing myth and fear is the common cause for the barrier. And the cultural taboos, the parents, they will not accept if the girl comes and tells means that they feel that it is a very out of the dignity and they will not give any idea. And the legal restrictions, financial restrictions, they may not have money to go to the hospital, where to go and get the contraceptive. If they know where the contraceptives are available only, they will go to the place and get the contraceptives. And the limited availability, the most of the married women, they know where the contraceptions are available and they will right royally get from the hospitals and even from the pharmacy. But the teenage girls, because of the fear, they do not get it from the pharmacy and they do not know the access to know where the contraception is available. The knowledge and attitudes of the healthcare provider, lack of confidentiality. So these are all the barriers which is affects the adolescents do not know about the contraceptions. So what is it is needed? Main thing to prevent the teenage pregnancy is counseling and the educations, the school counseling. It has to be given and they have to be told about what are all the side effects of the teenage pregnancy and what will happen if they have sex without the contraceptions. So ideally contraceptive counseling to be done before the initiation of the sexual activity. That is to, in when you give the school address school adolescent girls about the nutrition, menstrual hygiene, and about the vaccinations, you have to talk about the sexual activity also. And we have to tell them how the ovulation happens and how the pregnancy can happen. These are all the normal physiology which happens in the body, they should know. And the counseling should be between 13 to 15 years. We can conduct the counseling even at the earliest stages. And we have to discuss about the contraceptive methods, whether it is available in the tablet form, it is available in the injection form, and they should follow the condoms. And if they are very sexually active, they can also have the copper T incision, a small T-shaped contraceptive device which can be inserted into the uterus. And they should know about if they have the sex without the contraceptions or without the condoms, they can end up in the sexually transmitted disease. And the preventive services like HPV vaccine has to be given. That is a human papilloma virus vaccine that has to be taken before 18 years, 2 doses for the adolescent girls. If they that also has to be counseled to prevent the human papilloma virus infections. An adolescent friendly environment and adequate time for adolescent patient should be available. And privacy is very, very important. The adolescent girls should be talked and examined only in the privacy places. So the gather approach is very, very important in case of the contraceptions. The gather approach is used for the family planning counseling. That is from the 1980s. What is gather approach? That is G-GREED, build a rapport between the adolescent girls and the healthcare providers. We should make them ask questions. And you should ask some questions. What happened? Whether you have a boyfriend, whether you had sex, whether it is an individual partner or multiple partners. These are all the leading questions you should put. And you should make even the adolescents to question as what are all the types of contraceptions available. And you should give all the approaches available for the contraceptions. And tell the relevant regarding method for the contraception. You have to tell about the OC pills and you have to talk about the injections and what is the benefit of it, what is the negative of it, which will shoot for this adolescent girl. If they are obese, they can go even with the OC pills and help the client to reach a decision. If the adolescent girl comes with, if she comes with the pregnancy positive, you have to give her with following all the FOGSI Act rules. You can give her whether if she want to continue the pregnancy or whether she want to terminate the pregnancy. It is the choice of the client that has to be accepted, and we should help the client and explain about the methods which I told earlier and the return for ongoing contraceptive methods. And if the girls, if they are coming for the MTP in future to avoid the pregnancy, what are all the methods available? That has to be done. So you have to approach them with a gather approach. The counseling skills, whenever you address or counsel the adolescent, you should not be non-judgmental. The girl may be a good, or she may have some friends, that you should not have a non-judgmental and should give all the positive points, information available to them, and the importance of providing accurate information, sir, and the active listening. Make them listen what you are telling, and then you listen to what the adolescent speaks, sir. And the clear communications without the technical words. Some technical words they may not be understand. If you tell us condom, the girls may not understand. So you should tell what is that condom. It has to be inserted into the vagina. And after that, if you have sex, the sperm cannot go inside your uterus and you can prevent the pregnancy. This is the example. So like that, you have to tell them in the words which they can understand. That is the simple language. And respect people's right to confidentiality, privacy, and informed choice. The adolescents mostly, if they have confidence on you only, they will come to the healthcare providers. So the confidentiality is very, very important, and the privacy. The girls should be examined separately. Even they should be asking the parents to sit outside and talk to the adolescent girls or boys. And the non-discriminations, that is regardless of their age, family or social status, sexual behavior, and the kinds of the drug user. Whatever it is, it should be non-discriminatory. Non-discrimination should be followed with the adolescent. The improving adolescent access to use of the contraception is through these adolescent-friendly services, which includes the barriers. That is the provider attitudes, lack of confidentiality, limited method choice, cost of accessing service, limited client knowledge. This is the barriers which the adolescents have to know about the contraception. And the practice, incorporate adolescent-friendly service, delivery elements into the existing contraceptive and health services, what are all available. And the service delivery changes, non-judgmental, as I told you earlier, and audio and visual privacy, wide range of methods, what are all available, and free and the subsidized services, where the free services are available. They don't even need money to go for these services. And the community support, they can be counseled by the doctors, by the healthcare providers, even with the teachers and the parents. This community support is very, very important. So the benefits is improved knowledge of SRH and contraceptive services, better attitudes about contraception, greater access to and demand for contraceptive services. These are all the benefits. If they know the contraceptive services, you can prevent the teenage pregnancy and you can prevent the adolescent abortions and you can prevent the STI also if they go with the barrier methods. The outcome is increase in satisfied contraceptive use among adolescents and reductions in unintended adolescent pregnancy, which can lead to the contraception complications. What the ACOG recommendation is, that is, regardless of the patient's age or the previous sexual activity, the OGCN routinely should address their contraceptive needs, expectations, and concerns. And the right of minors to consent to healthcare services vary by states, depending on the state, whether it is a different states, the rights of the minors will vary. According to that state, the OGCN should address the adolescents. The other recommendations are emergency contraception can be routinely given even to the adolescent, and ACOG recommends that OG write advance prescription for oral emergency contraception for the patients. So the OC prescriptions can be given, and the long-acting reversible contraceptive methods have higher efficacy, higher continuation rates, and higher satisfaction rates compared with short-acting contraceptive. Therefore, LARC methods are safe and excellent contraceptives for adolescents. And before prescribing the OC pills, we should follow all the rules of the FOGSI Act. The ACOG recommendations of 2021, what they tell is discussion about the contraceptive should begin with the schooling itself. And the physician should be aware of and be prepared to address the most common misperception about contraceptive methods in a way that is age appropriate and compatible with the patient's health and literacy. The initial encounter and follow-up visit should include the reassessment of the sexual concerns, behavior, relationship, prevention strategies, testing and treatment for STIs as persons of disease control the guidelines. So I thank the organizers for giving these opportunities. The adolescent contraception should be the important counseling when we address the school case. Thank you.
Hi, friends. A very good day to you. Today we talk about contraception in the perimenopausal period. Today, over the next 10 to 12 minutes, I'll be taking you through an introduction, physiological changes occurring during menopause, contraceptive needs in perimenopause, contraceptive options, benefits and risks of contraceptive methods, especially in this age group, some special considerations, and transitioning off contraception into MHT, and a conclusion with references. The perimenopause is the period that precedes menopause and roughly a synonym of menopausal transition, beginning when there is a variable persistent length of more than 7 days difference of consecutive menstrual cycles, plus supportive clinical and endocrinological criteria. It starts on an average 5 to 10 years before actual menopause, around the age of 40 in most places. According to the stages of the menopausal transition, it comes into -1 and -2, according to the straw +10 staging system for reproductive aging in women. The benefits of using contraception during the perimenopausal stage is there is a chance of unplanned pregnancy because there is myths that you do not need contraception anymore, which isn't quite right, because there may be some amount of unpredictable ovulation, though there is a decline in fertility, of course, but sometimes you may have those badhai ho situations where you are becoming pregnant unexpectedly. So the benefits of using contraception would be the menstrual cycle control, which may be irregular at this stage, some reduction in bleeding, which will take care of your AUBO, a reduction of vasomotor symptoms due to hormonal deficiency and menstrual migraines, protection against bone loss, which is invariable from the age of 30 to 35 in case of women, a positive oncological risk-benefit balance, which is something which we know happens due to hormonal contraception. So menopause, is it the immediate end to fertility? Well, in most cases, yes, but it's not a zero. That's what I think is the important thing to understand. The fecundity, that is the average monthly probability of conception, decreases to half as early as mid-40s and less than 5% in 5 to 10 years, but not zero. I think that's something which is important. People may be surprised, how do they become pregnant? But yes, if you have intercourse, you can be pregnant almost any year, but at the same time, it would be much less above the age of 40. On an average, 1 in 1,000 women who believed that they were postmenopausal became pregnant naturally, typically a few months after their last menstrual period. Contraception agents to use, which would be ideal, well, you have to go through the medical eligibility criteria of WHO, but generally, if you're using hormonal contraceptives, there are different choices to take pick from. If there are no really medical contraindications, she can use birth control pills, patches, rings if available, and implants, and progesterone-only contraception for women with risk factors, which is prohibiting the use of estrogen in the contraceptive use. Non-hormonal contraception is, of course, very popular and is also quite commonly used. So coital interrupters, fertility awareness methods, barrier methods, and even a copper IUD inserted after the age of 40 can go for a very long time. Permanent contraception is always an option, especially for the male partner, considering the female partner took up most of the brunt in the reproductive age years. But that is something, again, which is a matter of choice, but it's a surgical procedure. So women with cardiac diseases, VTE, breast cancer, osteoporosis, you would not be allowing them to have generally any hormonal contraception, definitely not the estrogen containing ones. And again, you have the WHO medical eligibility criteria to follow. So contraceptive agents with caution, because a perimenopausal period is a period where a woman would be likely to have other medical conditions. Depending on what she has, you would like to choose whether hormonal contraceptives are appropriate for her or not. And if it's hormonal, whether it's a combined oral contraceptive pills or it's only the progesterone only. So here we have conditions like cardiovascular conditions, thromboembolic conditions, cancer, and other conditions in some where you would not be using hormonal contraception, especially the one containing estrogen in the combined oral contraceptive pills. So they're available in various forms. In India, it's mainly the tablets which we use, but the vaginal rings are available patchily. They can help to control common perimenopausal symptoms like irregular menstrual bleeding, heavy bleeding, menstrual pain, and vasomotor symptoms by supplying that little bit of estrogen which the woman is deficient in that point of time. It also reduces the risk of endometrial, ovarian, and colorectal cancer. And the hormonal-free IUDs can prevent pregnancy for up to 10 years. They're a very good option for a long-term reversible contraception where a woman or her partner does not need to go through a permanent sterilization. Pills containing estradiol valerate instead of phenylestradiol may be an appropriate choice because of their reduced effect on the lab-based coagulation, inflammatory, and metabolic events. Women having bleeding may have benefits from a continuous use also, where you can have periods once in 2 to 3 months rather than having it every month. Review for cardiovascular and bone density risks is advisable for women in their 40s. Coming to the progesterone only pill, as we have already mentioned, there are situations where an estrogen-free option would be recommended for women. This would be in like a case of breast cancer or a history of blood clots. And progesterone can come in different forms. The injectable, which is not the most preferred choice, but the oral pills, which is taken continuously, is one of the different options. And also implants or LNG IUS may also be used, which are options which can give them a lot of protection against the estrogen effects, or maybe some of the hormonal kind of have a benefit of contraception. The hormonal-free intrauterine devices can prevent pregnancy up to 10 years. They are a good option, and progesterone-only pill is also a very good option, though there may be some amount of unscheduled bleeding, but once counseled on the same day, most people would like to accept it. Coming to the IUCDs, the copper Ts, there are estrogen-free options, which definitely are some places where hormonal contraception is contraindicated. So this is something which can be kept for up to 10 years, and a person can avoid a permanent sterilization. Barrier methods, yes, male condoms can be used if there is an issue of erectile dysfunction. Then there is a problem of applying the condom, and that may be something which may affect compliance. Vasectomy, as we said, the female partner has taken up most of the brunt of the reproductive role in her lifetime. The male partner can always step up and have a vasectomy done. The LNG IUS, well, it has revolutionized as far as AUB management is concerned, and also has several benefits because it can give you the progesterone component, and the estrogen component can be provided through a tablet. That is one of the different ways, and also it provides very good, reliable contraception, and also controls abnormal uterine bleeding, especially AUB-O, AUB-E, AUB-A, which may be prevalent at this age. It also reduces dysmenorrhea and may be suitable for women where estrogen is contraindicated or where the estrogen is not given, and women in like polycystic ovary where there is already an estrogen excess. So choosing the right method, it would be involving the discussion with the woman. It's not something that you just give her. So you have to look at the medical eligibility criteria, see what is appropriate with her, what would not give her some risks. And the most common would depend on the woman's health status, risk factors, and of course, personal preference. Once you give her the options and discuss with them, you come out with a mutually agreeable solution. What do we not need anymore? Contraception is required. When do we not need it anymore? Yes, that's a very important question which many women will be asking. It is required for 12 months after the final menstrual period. If the menstrual period occurs after the age of 50, if it's before 50, it's 24 months of contraception is required. At least some form of it, because people may ask, till when can I become pregnant? I said after 40, after 45, your chances are very less, but that doesn't mean you will not be pregnant. You may get surprised once in a while. So, concluding this part of the discussion, menopausal hormone therapy is not a contraception. I think that has to be made very clear. Yes, it does help to tackle your menopausal symptoms, both the estrogen and the progesterone in some cases, but it is not a contraceptive method. Amenorrhea in women using hormonal contraception is not an indicator of menopause. FSH levels can be used to determine menopause in amenorrheic women above 50, including using progesterone-only methods, including the LNGIUS. The background risk of medical diseases like arterial vascular disease and venous thromboembolism may be present, has to be assessed, and then carefully methods have to be prescribed for her of contraception. LNGIUS has an extended use given after 40 or definitely 45 years at the time of insertion. You don't need to take it out for a long time. And comprehensive contraceptive counseling is essential in the perimenopausal woman to add to her overall health and well-being and addressing both the contraception needs and the hormonal deficiency that she would be encountering as her transition to the menopausal period. So here is a small checklist where you have the different methods of contraception and advice with the following. So if it's an LNG-IUS, POP, or a etonogestrel implant, that's a progesterone-only methods. Advise amenorrhea for more than 12 months. Check FSH twice, 6 weeks apart. If they're over 30, then you know that contraception only required for another 12 months. Continue until the age of 55, but usually we stop around 50. IUCD and barrier methods stop a method after 12 months of amenorrhea. DMPA usually not recommended beyond 50. Even after 45, you're a little hesitant to give DMPA unless you really need to. Switch to a non-hormonal method till amenorrhea for 24 months. And combined hormonal pills generally, again, not recommended, before the age of 50, and switch to a non-hormonal method until amenorrhea for 12 months, and switch to the other methods following method-specific advice. Thank you all for listening, and this is one of the references of this PowerPoint. It's coming from Australia College of General Practitioners, and it's on AF perimenopausal contraception. You can really look it up. Thank you for listening.
I, Dr. Yashodhara Pradeep, past President Vice President FOGSI, North Zone for the year 2023-24. It is my pleasure to be invited to deliver a talk on World Contraception Day. My gratitudes to Dr. Jaideep Tang, President FOGSI, Family Welfare Committee Chairperson, Dr. Ashish Kale, and his team, Dr. Priya Gupta and Dr. Kunal, who is organizing this event. World Contraception Day is celebrated every year on 26 September. The theme for this year is choices for all, freedom to plan, and power to choose. I would like to begin to say that this should be World Contraception. Instead of celebrating once in a year, it should be celebrated every day, because contraception is most important for the healthy mother and the healthy child. So we should not lose any opportunity to talk to a woman who comes to your OPD for any other problem, or who comes with the pregnancy for your for your advice. Because it is a 9 months. If we do not start the counseling in the beginning of the pregnancy, it will not happen. The woman is not prepared to what to do for the next pregnancy. If she comes to the OPD for any other problem, it is wise to ask whether she is using any contraception or not, whether she wants more children or not. What is her plans? If she says no, she does not want more conception, more children, then becomes our duty to treat her for the problem for what she has come, and also to suggest, counsel her what she should do so she can avoid unintended pregnancy. Today, I am going to talk on one of the contraceptive method, the LNG-IUCD. The LNG-IUCD is a very effective method of contraception, although it is expensive and it is not available at the moment, it is not available in the basket of choice from the Government of India. Although the efforts have been made and people are trying to get it into the basket of choice, and I'm sure it will be added into the basket of choice for the benefit of all the women health and child health. We use LNG-IUCD for abnormal uterine bleeding. So as I have said in the beginning, that once we are treating her for abnormal uterine bleeding, we should also ask whether she wants any more conception or not. If she does not, then it will be wise to say that this device is going to treat her abnormal uterine bleeding, as well as it is also going to give her the protection from the unintended conceptions. LNG-IUCD is a highly effective method of contraception. It's a derivative of 19-nor-testosterone. It comes in the different sizes. So it's a maybe 32 into 32 millimeter. It's a 32 into 28 millimeter, but widely available is 32 into 32 millimeter in India, which has got 52 milligrams of the levonorgestrel. The compound is also used for the progestogen only contraceptive pill, or in the emergency contraception also. Only the doses are different. The strength of the pills are different. So here, this LNG-IUCD has got 52 milligram of the levonorgestrel, which is going to release 20 microgram of levonorgestrel per day, which is going to rise the plasma levels by 150 to 200 picnogram, which is sufficient for the contraception and also for the treatment of abnormal uterine bleeding. This LNG-IUCD is made up of polydimethyl siloxane, and it is the FDA has approved it for 5 years. Although in India it is used only for 3 years, but the research show that it can be used for the 5 years. Mechanism of action. It is a highly protective method. It's a second generation IUCD, and contents are, as I have already said, the levonorgestrel, which has also been used for progestin-only pills and also for the emergency contraception pills. The best part is that it does not inhibit the ovulation always, because the amount released and the plasma levels does not inhibit the ovulation. So the woman may continue to ovulate, but it alters the endometrium thickness. So endometrium becomes thin and the cervical mucus thickens. So it protects from the ascending infections, and it affects the implantation. The tubal mortality is also reduced. So in case if the ovulation occurs, the sperms are there and it is fertilized, the ova by the time comes to the endometrial cavity, the endometrial lining is not good enough for the conception. So that is how it works, and it's highly effective. As I said, its failure rate is less than 0.01%. But one should know when to use. So it can be used anytime, within 7 days of the menstruation, post-abortion. It can be used if there is no signs of incomplete and no signs of sepsis. It can be used postpartum also. But mostly it is being used day 7 of the menstruation, day 5 to 7 of the menstruation, and it is a post-abortion. When it cannot be used, if there is any pregnancy, if there is any signs of sepsis, endometritis, and if you are in doubt for the malignancy, then this woman needs to be investigated for the cause of this abnormal uterine bleeding. Here, once we are doing the contraception, we should not forget that this woman should also be protected for the other things, like screening for the cervical cancer can be done at the same moment. Before inserting the IUCD, one can take the pap smear and it will give the results for her, and at least she will get one chance, one opportunity to get her pap smear done. And then at the time of follow-up, we can also reinforce the benefits of the LNG IUCD. As I have already said, it does not only treat the abnormal uterine bleeding, it also protects from the contraception, and it is also the opportunity to meet the health care workers to get more information about other problems like the cervical cancer. So it is essentially that counseling is must. She should be told its benefits and limitations. So it is essential to say that it can, after insertion of IUCD, the woman may have unpredictable vaginal bleeding, which sometimes may be not very well acceptable. But if you have done a good counseling to her, that this is the benefit. So if you are having problem, you have come for the solution. If that solution has got a little bit of inconvenience, I'm sure you are going to accept it, because gradually this unpredictable bleeding will go away, and it will lead into a amenorrhea. So sometimes this amenorrhea is also not very well acceptable for these women. Again, if she is not accepted, then you should not. But it is not that all women is going to be amenorrheic. Some women may bleed having the prolonged cycles. So she can start. If she does not like it, it can be removed whenever she wants, or whenever she wants to conceive. So it is must to learn how to insert LNG IUCD. So there is always, when you buy, or when you get the LNG IUCD representatives bring you the simulator, and in which you can practice and learn how to insert LNG IUCD, because it is not a very cheap device. It's not available at the moment with the government basket of choice. If it is available still, we should not waste it. So we have to learn the technique, how to insert it, and follow the instructions. The expulsion of this IUCD can occur most of the time within 2 weeks. So we always like to follow this woman after 4 weeks or 6 weeks to see that it is in place. And we also tell to the woman she should be a little vigilant to see while defecation or while urinating or while something, she should not have expelled it herself, because then she will not be protected. So if she is using this, choosing this contraception, LNG IUCD for the contraception, while changing her method of contraception, the one must see that she is being given some protection or some instruction that it is effective immediately or it takes 7 days. So in this cycle, because these 7th day, if 5th to 7 days we have inserted, it is better to say that she should use the barrier method for the safety of it. So this ovulation she should not consider, because the process has already started. So proper insertion is must. Follow-up of this device is also required. So 6 to 12 weeks after the first placement is advisable. And then she can come whenever there is any problem. There is no need to check the strings. If she is concerned, she can check her IUCD. It should be explained how she can check. But it is not at all necessary that she has to check this. Routine ultrasound is not recommended for placement or for any other thing, unless she has got any abnormality. Women should be informed of the date on which this IUCD is going to be replaced. So there should be a card should be given in which the date and time of insertion should be written. And then the follow-up visit should be mentioned. And she should be asked to come back for the replacement of this IUCD. As I said, Government of India has approved it for 3 years. Otherwise, it can be used up to 5 years. So at the end, I would like to say that it is effective, safe, acceptable method of contraception, easily reversible, because it can be taken out whenever the person is want. No maintenance is required. So every day you do not have to use anything. It is not at all interfere with your sexual activity, and can be used in at any for any other indication where the estrogen is not effective. So it reduces the non-contraceptive benefits, as I said, that it reduces the blood loss. So indirectly treats the anemia, because this blood loss is going to be saved. So she is not going to have any she is going to improve her iron levels. There is a lower risk of pelvic inflammatory disease, as I said, because it thickens the cervical mucus. It reduces the pain in the patients with the deep infiltrating endometriosis, because the estrogen is not there, or in the adenomyosis, and reduces the menorrhagia in patients who are presenting to you with the fibroids or with the menorrhagia. Most beneficial is menstrual disorder, and the woman with heavy menstrual bleeding is going to be benefited. And it reduces the possibility of estrogen-dependent conditions like polyp and the fibroid or the adenomyosis. Thank you so much for giving me this opportunity and making me the part of this program of the World Contraception Day, 26 September. Thank you very much.
So welcome to this World Contraception Day, 26 September 2024. In the next 10 minutes, I will simply walk you through the new contraceptives which is now available in India in both the public sector as well as the private sector. The contraceptive implant is not new to the world, and it is also not new to the people in India. Earlier on, ICMR had conducted trials for the 5-rod implant, and later on they conducted trials with the single-rod contraceptive implant. So let's have a look of what is the current status of the availability of the contraceptive implants in India and globally. Now, currently there are only 2 types of implants available globally, 1-rod and 2 rods. In India, only 1-rod implant called Implanon NXT, which is a single rod implant, is available. It contains etonogestrel 68 milligrams, and it is a matchstick-like device 4 centimeters in length and 2 millimeters in diameter. The Jadel is the most commonly used contraceptive globally. It has got 2 rods. It contains levonorgestrel. Each rod contains 75 milligrams. This is also 4 centimeter long and 2.4 millimeter in diameter. In some countries, Levoplant is used, which is again a 2-rod implant, contains levonorgestrel 75 milligram. Now, the approved duration of the contraceptive implant in India, which is the Implanon NXT, is 3 years, whereas that of the Jadel, which is a 2-rod, is 5 years. Levoplant, though it's 2-rod, but it is approved only for 3 years. Let's have a little look at what is a contraceptive implant. It consists of a single flexible non-biodegradable rod, contains 68 milligrams of etonogestrel. What is etonogestrel? It is the active metabolite of desogestrel, a 19-nor-testosterone derivative, and it is impregnated with barium sulfate, which makes it radiopaque, and it is easy to trace once inserted inside the body. It is inserted subdermally in the upper arm, which is the dominant arm. It releases 60 to 70 micrograms of the hormone in the initial few weeks, and later on at the end of the first year, it comes down to 45 micrograms. At the end of the 3 years, it becomes further less, which is 25 to 30 micrograms. Now, as I said already, it is effective for 3 years and the half-life is 25 hours. It starts working at the same day, that is within 8 hours of insertion. The hormonal level is sufficient to provide contraception. It's highly effective with a failure rate of just 0.05%, and once removed from the body, the blood levels, the serum levels, they disappear within 7 days. Now, what is the mechanism of action? The mechanism of action is through inhibition of ovulation. The serum level of 90 picograms is required, which is achieved easily the very next day after the insertion. Now, another important point about this is that though it inhibits ovulation but doesn't stop the follicular activity altogether, some estradiol is secreted that makes it different from the DMPA. So because the estradiol is there in the body, the bone mineral density is not affected by contraceptive implant. Now, there are other mechanisms also other than the ovulation inhibition. It thickens the cervical mucus and thins the endometrium. It has various benefits, both contraceptive as well as non-contraceptive. It is a simple walk-in procedure which is required, and once inserted, it is effective for 3 years. And it is completely reversible, and the return of fertility is early. It does not interfere with the sexual intercourse, and the women may not undergo a pelvic examination if they don't desire so. Of course, the provider should use the medical eligibility criteria for looking at the eligibility of the woman. It can also be given to women who have a blood pressure of more than 160/100. And the good part is that soon after delivery, this contraceptive implant can be inserted. So it can be given to married, not married, nulliparous or multiparous women without affecting any other function. Now, just a few words about how is it inserted or when is it inserted. So it should be inserted just like other contraceptives within its first 7 days of the menstrual cycle. But if the woman comes late, she should not be denied the benefit. But a pregnancy should be ruled out, and she should be asked to take a backup method for the next 7 days. It can be inserted concurrently with the medical termination of pregnancy and soon after delivery. Now, how is it inserted? So, the non-dominant upper arm is the site where it should be inserted. This is a very important point, that the mark where the needle should go for insertion, the puncture site, should be very, very carefully and meticulously marked. So it should be inserted of 8 to 10 centimeter towards shoulder from the medial epicondyle. So one has to identify the medial epicondyle using a scale, mark a point 8 to 10 centimeter towards shoulder, and this point should lie 3 to 5 centimeter below the sulcus or the groove between the biceps and the triceps muscle. So once the first mark is given, the second mark is 5 centimeters away from the first mark. Now, this is very, very important, because if the groove is not identified, you will not be able to go 3 to 5 centimeters below this, and an insertion within the groove or very near the groove can lead to deep insertion and cause complications later on. Now, if you look at this is the device. You may see more pictures later on. So once the implant is inserted, the provider should palpate and see if it is both the ends are palpable and it is superficial or subdermal only, and even the client should be asked to try and feel it. So this is very, very important. Well, of course, the implant has some limitations. One is that a specific skill is required, as I said, for not just for counseling, medical eligibility screening of the client, identifying the site and doing the insertion. A skill is required. It's a short training which the providers, if they choose, they can easily undergo, and even videos are available. Skill is also required for removal, though it's not a very complicated skill. All gynecologists can perform it very, very easily. Coming to the side effects are low, and there may be menstrual irregularities. In fact, that's a side effect which all hormonal contraceptives and even non-hormonal like IUCD do have. So this hormone-induced bleeding problems are there, and a proper thorough counseling is required for that. Other minor side effects could be acne, breast tenderness. Weight gain is possible, maybe 1 to 2 kgs a year, but not more. The possible complications are bleeding, and if infection prevention practices are not followed, there could be some infection and some expulsion. There are rare complications which are migration of the implant to the distant side, and that these are all provider related complications. Now, a few words about the menstrual bleeding patterns for the implanon users. So the Amenorrhea is seen in 22% of women. Infrequent bleeding is seen in 33.6%. Prolonged bleeding in 17% and frequent bleeding in 6.7%. Overall, discontinuation due to the menstrual changes was 11.3% in the study. Now, complications for implant are rare. Of course, there could be infection at the insertion site if proper precautions are not taken. Difficult removal if it is not inserted properly, and expulsion again very rare, and migration to other sites again due to lack of proper skill while inserting the implant. Few words about migration. There were some reports of migration, but then the technology was added to the single rod implant and even the other implants. So the device was modified to include barium, thereby allowing localization with normal X-ray, CT. So the applicator was redesigned. The one that we are using in India currently is barium impregnated implant, and the applicator is the latest, most recent one available. So when inserted properly in accordance with the manufacturer's instruction, the implant can be readily located via simple palpation. Ultrasonography using the linear array transducer 10 to 12 megahertz is recommended. MRI may also be used. So just a few final tips and takeaways: that one should attempt removal only if it is adequately localized and is palpable. Start removal procedure if the location of the implant is unambiguously confirmed by palpation or appropriate imaging method. Exploratory surgery without the knowledge of exact location of the implant is strongly discouraged. The family planning experts can use their judgment to proceed removal on their own or to refer to better experts. Thank you.
Now, regarding types of injectables, here we have two types. One is progesterone only injectables and another is combined injectables contraceptive, which contains estrogen, ethinyl estradiol and progesterone in a monthly basis injections. Whereas we are talking about progesterone only injectables, also known as LARC, in which it contains only synthetic progesterones, and there is two types. One is depot-medroxyprogesterone acetate, which is being given every 3 months injectables, and second is norethistron ethantate NET-N, which is given at 2 months intervals. Regarding route of DMPA injections contraceptive, it can be given intramuscular, can be given subcutaneous. Regarding intramuscular, we have single dose vial with a disposable syringe and needles, and there is also available pre-filled syringe with needle. And regarding subcutaneous depot of medroxyprogesterone acetate, we have pre-filled auto disable syringe which is known as in Uniject system. Squeezing bulb pushes the fluid through the needle. Now, regarding intramuscular, we know that it is a crystalline suspension delivered intramuscularly at a dose of 150 milligram in 1 ml at 1-2 recommended sites. It can be given in the upper arm or can be given over the buttock, but the buttock is more preferred choice. It can be given 3 monthly, which is effective and is completely reversible, also known as LARC, and has a 4-week grace period for users unable to return for injections exactly on the scheduled date. It is available by various manufacturers for the last 40 years and approved by regulatory agencies in more than 179 countries. Now, there are various advantages and disadvantages of this contraceptive injectables, depot of medroxyprogesterone acetate. Regarding advantage, it is infrequent dosing is there, which is better tolerated by the females. Non-contraceptive benefits such as reductions in dysmenorrhea, premenstrual symptoms, heavy menstrual bleeding, fibroids, anemia, seizures, and sickle cell crisis can be benefited by giving this Depo-Provera. Regarding disadvantages, there is difficulty in accessibility for injections, unscheduled bleeding can occur, delayed return to fertility, there is weight gain also, and reversible bone mineral density loss can be seen after giving these injections. Regarding Uniject, it is a low dose formulation of depot of medroxyprogesterone acetate that allows for subcutaneous delivery, and this contains only 30% less active ingredient than the intramuscular form. Subcutaneous version is effective for 13 weeks, is reversible, and has a re-injection grace period of only 1 week early or 1 week late. Now, this subcutaneous and intramuscular are equivalent. Many researchers suggest that subcutaneous may offer advantages over intramuscular injections because there is lower hormone doses, easier administration, potential for self-injection, and increased long-term tolerability with subcutaneous injections. Now, regarding Uniject, we all know that it comes in a pre-filled single-use injection system that consists of a blister reservoir and a pre-attached needle. Patient or providers administer medication by inserting the needle into the subcutaneous layer, typically in the thigh, upper arm, or can be given over the abdomen, and squeezing the blister to inject the medication. It is a one-way valve, prevents refilling, thereby reducing the risk of reuse and infection transmissions. While subcutaneous injections is the newest medication available as in the form of Uniject, the system has been used to deliver a number of medicines and vaccines by providers including nurses, midwives, and self-injectors. Now, coming to comparison between the two, the intramuscular and the subcutaneous one. The subcutaneous is available in a single dose pre-filled auto-disabled injections device named as Uniject, whereas intramuscular is available in single dose vials. Regarding dose, single dose contains 104 milligram in 0.65 ml of medroxyprogesterone acetate, which can be given subcutaneously to be administered every 3 months. Regarding intramuscular, single dose contains 150 milligram in 1 ml of medroxyprogesterone acetate to be administered every 3 months. Regarding site of administration, it can be given subcutaneously in outer part of the anterior portion of the thigh, abdomen, or upper outer portion of arm, whereas intramuscular injection can be given in upper arm, hip, or outer side of thigh. Mode of administration is also important because it pierces the epidermal and the dermal layers of the skin and delivers drug in loose subcutaneous tissue when we are giving subcutaneous. Needle is very short and ease of administration is more with this subcutaneous one because there is more surface area available and fewer landmarks needed for subcutaneous injections, whereas in intramuscular it has to be given deep intramuscular, long needle is there, and ease of administration we see that there is less surface area and particular landmarks needed to locate specific muscles. Now, regarding effectiveness, we all know that it is highly effective contraceptive method, and with a standard regimen, the first year effectiveness is 99.7 when the drug is used correctly. The perfect use failure rate of is only 0.3%, is lower in comparison to 0.5 of female sterilization, 0.8 of IUCD, and 3% of combined oral contraceptive pills. So, we can see that how effective this intramuscular Depo-Provera is. So, effectiveness depends on timing of first injection, taking injections regularly on time, the injection technique, and post injection care is also very important. Now, regarding bone effects, we see that with this Depo-Provera or depomedroxyprogesterone acetate injectable contraceptive, bone mineral density decreases by 5 to 6% in 5 years, with most loss happening in first 2 years. It also interferes with the production of the hormone estradiol, which is very important for bone mineral density. It is reversible on discontinuation. There is no increase in fractures, and routine bone mineral density monitoring is not recommended when we are taking Depo-Provera. Now, in regarding giving in adolescence, we see that users will show a slower increase in bone mineral density values when used over 2 years period compared to non-hormonal users, and complete recovery of BMD is seen within 3 to 5 years, and there is no effect on subsequent fertility. And WHO also recommends that Depo-Provera can be used safely in adolescents. Now, it has got effect on metabolic also. Minor weight gain of 1 to 2 kg after 1 year of use can be seen. Weight gain may also occur due to other reason also. It's not because of only this taking Depo-Provera, we have to see into it. And only 2% of women stop using this Depo-Provera because of weight gain. Now, coming to women who is postpartum and she is breastfeeding, when to start? If she is less than 6 months postpartum, we should wait until 6 weeks postpartum, and then we should start depomedroxyprogesterone acetate. Can be started any time between 6 weeks and 6 months. If she is fully or nearly fully breastfeeding and her monthly bleeding has not returned, no need for backup is required. But it can be started at any time between 6 weeks and 6 months if she is partially breastfeeding and her monthly bleeding has not returned, and if it is reasonably certain that the woman is not pregnant, she will need a backup for 7 days after this injections. If her monthly bleeding has returned, she can start injectable as advised for women having menstrual cycle, that it should be started within 5 to 7 days of the menstruation. Now, if she is breastfeeding in that and she is postpartum more than 6 months, in that case it can be started any time if her monthly bleeding has not returned, and if it is reasonably certain that the woman is not pregnant, she will need a backup method, condom, for the first 7 days after this injection. If her monthly bleeding has returned, she can start injectable as advised for women having menstrual cycles. Now, if she is not breastfeeding, in that case when to start? If she is less than 4 weeks after giving birth, can be started at any time and no need for backup method. More than 4 weeks after giving birth, it can be started any time if her monthly bleeding has not returned, and if it is reasonably certain that the woman is not pregnant, she will need a backup of condom method for the first 7 days after the injection. And if her monthly bleeding has returned, she can start injectable as advised for women having menstrual cycle. So, this is all about LARC, this long acting reversible contraceptive, and I think it is a very effective method and also very useful when the woman takes very routinely, and every 3 months she used to take, and it is a very effective method. Thank you very much.
Good morning, dear friends. This is Dr. Rakhi Singh, and I'm going to talk today about the barrier methods of contraception on the World Contraception Day and Committee of FOGSI. When we talk about the barrier methods, it prevents the sperms from entering the uterus, thus preventing fertilization and pregnancy. They include condoms, diaphragms, cervical cap, contraceptive gels, contraceptive sponges, and spermicides. Condoms are the only method that also prevents sexually transmitted diseases, and which also includes HIV. There are various methods, either the male condoms or the female condoms. When we talk about male condoms, it is a sheath or a covering made to fit over a man's erect penis before the penetration and prevent semen from coming in contact with the cervix and vagina, forming a barrier preventing the infections and the pregnancy. Made of various materials like latex, lambskin, polyurethane, silicone, or rubber. Usage, when we talk about, it is correct and consistent use is crucial. Apply before the penetration, ensure no air bubbles are present, and dispose of safely has to be done. When we talk about the female condoms, it is thin, transparent sheets or the lining with flexible rings at both the ends, which are there, that fits loosely inside the woman's vagina, either made up of latex, polyurethane, or the nitrile. When we talk about the usage, insert before the physical contact and ensure the penis enters the condom and we do not reuse it. There are also the other methods of barrier, which could be the spermicides, the foaming tablets, or the suppository, which are the melting suppository, soluble films, or the jellies and the creams, and are used as a vehicle for the chemical agent that inactivate the sperms in the vagina. Nanoxyl 9 is the commonest chemical used in these preparations. Diaphragm, when we talk about, it is a soft rubber cup that covers the cervix to act as a barrier, and efficacy increases when it is used with a spermicidal jelly or the cream. Cervical cap, it is like a diaphragm, but a very smaller size of just fits snugly over the cervix. And it is not available in India and widely available outside India, that is in North America, Europe, Australia, and New Zealand, and less effective in the multiparous woman. When we talk about the sponges, these are the typical, it is a physical as well as a chemical barrier with a sustained release system of spermicides. The sponge absorbs the semen and blocks the cervical canal. Commonest available preparation is today containing around 1 gram of nanoxyl 9 and may cause allergic reaction in about 4% of the users, and vaginal dryness, soreness, itching in about 8% of the users. It does not cause a toxic shock syndrome and may enhance HIV transmission by damaging the vaginal mucosa. When we talk about the failure rate, when the patients are using it perfectly, then the failure rate definitely goes down to less than 20%. When they're not being used very perfectly, then the failure rate is somewhere around 13 to 32%, like in male condoms, 13%. Female condoms is little high, around 21%. Diaphragm and cervical cap is around 17% and 32% in the parous woman, whereas spermicidal jellies has around 21% in the typical rate, and contraceptive gels is 14%. And contraceptive sponges, which is today is around 16% in nulliparous and 32% in the multiparous females. When we're talking about the advantages of barrier method, they are safe, non-hormonal, use as a regular or temporary or backup method, can be used without seeing the healthcare provider, available easily without a prescription, relatively inexpensive, and even freely distributed at the government health centers, no delay in the return to of fertility of both the partners, helps in protection against both the pregnancy, sexually transmitted infections, including HIV, may help to protect against the condition caused by sexually transmitted diseases, recurrent pelvic inflammatory disease, chronic pelvic pain, chronic cervical cancers, ectopic pregnancy, infertility, male and female patients. Safe to be used by the lactating mother. Additional advantages of the condoms could be encouraging the male participation, only method which prevents HIV and AIDS when used correctly and consistently with every act of intercourse, can be used immediately after the childbirth or abortion. Female condoms of the diaphragm or cervical cap has an additional advantage that it may be helpful to insert the head inserted ahead of time and do not interrupt the sex. When we talk about the disadvantages of these barrier methods, the allergic reactions could be there. Urinary tract infections could happen because of the use of the diaphragms and the spermicides. Accidents like spillage, breakage, tear during the coitus necessitates a backup use of emergency contraception. Careful storage is required from the heat, sunlight, and excessive humidity. Require heat motivation, as it is embarrassing to some people to buy and ask partners to use these methods. Diaphragm and cervical caps do not protect against HIV and AIDS. A male or the female condom should be used with them to provide additional protection for the sexually transmitted diseases. Use of diaphragms and the cervical cap require pelvic examination by trained provider to assess the size and fitting, which may change after the childbirth. When we are talking about the contraindications of the barrier method, 6 weeks after the childbirth or the second trimester abortion for the diaphragm and cervical cap, and severe allergic reaction to latex can happen. Women with history of toxic shock syndrome, Mullerian anomalies of the genital tract, where it is contraindicated. A word about the emergency contraception as a backup for the barrier method. The main disadvantage of barrier method, like condoms, is protection against the sexually transmitted infections and HIV/AIDS. For individuals at risk for sexually transmitted infections, the condom use is critical. Women and men may feel more confident on relying on the condoms for birth control if emergency contraception is available to them as a backup. When we talk about the barrier method as a postpartum or the post-abortal contraception, in postpartum period, the condoms can be used effectively immediately anytime after delivery, although the diaphragm and the cap should only be used after 6 weeks once the uterine involution is complete. Barrier methods have no effect on breastfeeding and offers dual protection for RTIs. Condoms, diaphragms, and caps can be used immediately after the first trimester abortion and post-septic miscarriages also. To conclude, barrier methods of contraception are the most effective coital dependent and contraceptive method for preventing unintended pregnancies and STIs. Consistent and correct use of crucial to maximize their effectiveness irrespective of the method chosen. They are specially suitable for the woman with medical conditions that preclude the use of hormonal contraception.
Every year, we celebrate Contraception Day on 26th of September, and it would be a successful celebration if we are able to ensure that all the women or the girls who need a contraception get it as per their choice. Preventing unwanted pregnancies, unintended, unplanned pregnancies is the objective of use of contraception. Of course, there are other uses also where the barrier methods also help in preventing infections also. But coming back to the point of preventing unwanted pregnancy, it really helps in the overall improvement of the women's health. We are in good times where there is a lot of choice from where the women and the girls can choose their method based on their reproductive goals, their age, their stage, their compliance factors. What can they do? Can they take a daily doses, or they want just a long-term methods? In the recent times, the long-term methods also have become very popular and are really effective and safe. So when we have a whole basket of so many methods available, short-term, long-term, permanent, spacing, delaying, I think the only thing that's perhaps lacking before it becomes like of true benefit to the women of our country is making them aware of its accessibility, its availability, its use, its advantages, its other features, what to be cautious about, what are the precautions while its use. So finally, everything boils down to awareness and information or the knowledge about the choices that are available. So on this World Contraception Day, let us all, as providers, as women, as gynecologists or doctors, fulfill our duties towards making this awareness for all women in the reproductive age group who need this contraception, and help them lead a very fulfilling life where they do not have to bother about unplanned pregnancies, or they do not have to bother about their health conditions. So let's all come together and make this a success for every woman in the country.
So we'll have a view of about contraception usage when it comes to special medical situations or gynec conditions. First of all, we'll talk about the neurological disorder in contraception. Whenever a patient comes with a headache to you, we have to find out whether the patient is having migraine or it's a non-migrainous headache. If a patient is a case of non-migrainous headache, then all the contraceptives are taken as category MEC1. And a person having migraine but without aura and the age is less than 35 years of age, then copper, IOD, and POPs are categorized as MEC1. And we have to be cautious while using the combined hormonal contraception, the LNG-IUS, implants, and DMPA. If a patient of migraine without aura and age is more than 35, then copper IUD again, along with the progesterone-only pills, are MEC1, and LNG-IUS implants and DMPA are categorized as MEC2. But when it comes to age more than 35 years, we have to use combined hormonal contraception judiciously, and so they are categorized as MEC3. If a patient of migraine with aura comes to us for the contraception, then copper IOD is the safest choice, and the progesterone-only pills, LNG IUS, implants, DMPA, they are all categorized as MEC3 because we all know that progesterone causes water retention to a certain extent, and a migraine with aura, such patients are categorized, have to be really cautious while using these. And the combined hormonal contraceptives are almost contraindicated and are categorized as MEC4 when it comes to a migraine patient with aura. If a patient of epilepsy history comes to us for the contraception, then copper intrauterine devices, the LNG IUS and DMPA are comparatively safer choices and are categorized as MEC1. And combined hormonal contraception and implants are taken as MEC2 category. We are all aware that these estrogen-containing contraceptives are contraindicated in migraine with aura because of the increased risk of stroke in such patients. Diabetes is a very common ailment which we see even in pregnancy and without pregnancy. So whenever a patient of a history of gestational diabetes approaches us for contraception in the postpartum time, then all the contraceptions are usually taken as MEC1 when it is only a case of gestational diabetes. But when the diabetes is of a longer standing duration of more than 20 years, but the diabetes is not having any vasculopathy, then copper intrauterine devices are the safest choice to be used as MEC category 1, whereas POPs, LNG-IUS, implants, DMPA, and the combined hormonal contraceptives are taken as MEC category 2. If a diabetes is associated with nephropathy, the retinopathy, neuropathy, or a vascular disease, then also copper intrauterine devices are the safest choice to be used as contraception. They are category MEC1. And the progesterone-only pills, the LNG IUS and implants are taken as MEC category 2, and DMPA is taken as 3 because we all know that DMPA favors atherosclerosis. So when it comes to vasculopathy, then DMPA is taken as MEC category 3, and the combined hormonal contraceptives are MEC4 if it is a case of severe disease. So in patients with microvascular complications of diabetes, CSC increases the risk of vascular thrombosis, so it's categorized as MEC4. Combined hormonal contraceptive is also not suitable in women with diabetes mellitus and other risk factors like smoking, obesity, and hypertension, because these conditions also increases the risk of MI, stroke, and venous thromboembolic phenomena. When the patient of ischemic heart disease approaches us for contraception, or a case of stroke, or a case of multiple cardiovascular risk factors like obesity, hypertension, as we have talked about, in such cases, copper intrauterine devices are taken as category MEC1 and are the safest choice to offer to our patients. Whereas progesterone-only pills, the LNG IUS and implants, they are categorized as MEC2. DMPA, dipomedroxyprogesterone acetate, is category 3, and combined hormonal contraceptives are MEC4. Whereas when a patient of cardiovascular risk factors approaches us and is not having any disease as such, in that cases, we may use combined hormonal contraceptives in MEC category 3. But a patient of cardiomyopathy with a normal cardiac function, in such cases, the combined this POPs, the copper IUDs, LNG IUS implants, and DMP all can be offered. Whereas a case of cardiomyopathy but with an impaired cardiac function, the POP, copper IUD, LNG IUS implants, and DMP are the category MEC1, whereas combined hormonal contraceptives are rarely contraindicated. And we are all aware that this DMPA preparations are associated with atherosclerosis. CSC is associated with increased risk of venous thromboembolic phenomena, stroke, and myocardial infarction. So in a case of patients where we are suspecting cardiac problems, the combined hormonal contraceptives are the least preferred choices amongst all the cardiac problems. When a patient of valvular heart disease approaches us, but the valvular heart disease is uncomplicated, then we can offer our patients POPs, copper IUDs, LNG IUS, implants, and DMP as the first choice, whereas combined hormonal contraception is category 2. When a patient of valvular heart disease is complicated with a pulmonary artery hypertension or with endocarditis or with fibrillation, in such cases, the POPs, implants, and DMPA can be given as MEC1, whereas even copper IUD and LNG IUS are taken in category 2 because they may predispose the patient to increased risk of infection. And the combined hormonal contraception is categorized as MEC4. In a case of atrial fibrillation, copper IUD is one of the good choices, whereas progesterone-only pills, LNG IUS, implants, DMPA are taken as MEC2 and CSCs are MEC4. In a case with long QT syndrome, copper IUD, if continued initially, can be continued. But you cannot make initiation of copper IUD whenever a patient is having long QT syndrome. Initiation of copper IUD is taken in MEC category 3. The POPs, the implants, and LNG IUS are the safest choice as MEC1. The COCs and DMP are MEC2, and LNG IUS and the initiation of copper IUD is again taken as MEC3 because of the risk of infection. So, increased risk of vascular thrombosis, stroke, and myocardial infarction has to be always taken into account whenever we are advising contraception to a case of heart disease, whether it's a valvular heart disease or a functional one. Now, coming to the hypertension, which is the most common patients entering our OPD, majority of the patients beyond the age of 30-35 years are having hypertension. So if it's a case of mild variety of hypertension, that is 140 to 90 or 299 mm of mercury and adequately controlled, then we can give progesterone-only pills, LNG IUS, implants, and copper IUD as MEC1, whereas DMP is taken as MEC2 and CSC as category 3. But a case of severe hypertension more than 160 by 100 millimeter of mercury, copper IUD are a better choice. Here, the progesterone-only pills and LNG IUS or the implants like these all progesterone derivatives are MEC2. DMP is taken as category 3 and CSCs as category 4. Again, a case of hypertension but with vascular disease, copper IUD is the safest choice. All the progesterone derivatives are taken as MEC category 2. DMP is taken as category 3 and combined hormonal contraception are the least preferred. A patient of gestational hypertension history can be offered progesterone-only pills, copper IUD, and implants as the primary choice. But the combined hormonal contraception and the LNG-IUS are taken as MEC2. After the usage of contraception, the annual blood pressure assessment is rarely recommended, and we have to screen the patient repetitively for the cardiovascular and the renal disease development. We are all aware about the combined hormonal contraception that it causes fluid retention, and this leads to elevated blood pressure, which is mediated through renin-angiotensin system, and discontinuation of combined hormonal contraception in women with hypertension may improve the blood pressure. In cases of venous thromboembolism and contraception, when there's only a history in the medical condition, then copper IUDs are taken as MEC category 1, whereas POP, DMPA, LNG, IUS, and the initiation of implants are taken for MEC category 2. If the patient is already having an implant, then the patient can continue that implant, but it is risky and taken as MEC category 3. Whenever a patient of acute venous thromboembolism reports to our OPD, then again we can offer copper intrauterine devices as the category MEC1, whereas these progesterone derivatives are taken as MEC category 3 and CSCs as MEC category 4. If a patient of thromboembolism has undergone a major surgery and is having prolonged immobilization, then again copper intrauterine devices are the safest choice, and these POPs, DMP, LNG, IUS, and implants are taken as category MEC2, whereas CSC is taken as category 4. But a patient of major surgery and without prolonged immobilization, we can offer copper intrauterine devices, progesterone only pill, DMP implants, and LNG IUS as category 1 to such patients, and combined hormonal contraception can be offered as category 2. If a patient is having only a minor surgery without immobilization, then again the copper intrauterine devices, these implants, DMPA, progesterone only pill, the LNG, IUS, and even combined hormonal contraceptives are included in MEC category 1. When it comes to immobilization, which is unrelated to surgery, then we have to be cautious only while using this combined hormonal contraception. In varicose veins, all the contraceptives can be taken as MEC category 1. If a patient of superficial venous thrombosis reports us, then excluding combined hormonal contraceptives, all can be used in category MEC 1. If a patient with a known thrombogenic mutations, example factor V laden, prothrombin mutations, proteins, protein C, and antithrombin deficiencies, they report to our OPD, then again also copper intrauterine devices are one of the safest choice to be offered, whereas POP, DMP, LNG, IUS, and implants, and even CSCs are taken MEC 3 and 4 respectively. Now, coming to the gynecological conditions and contraceptions, if a patient of irregular vaginal bleeding comes to us, but it's without heavy bleeding, then we can offer that patient copper intrauterine devices, the LNG intrauterine system, and even combined hormonal contraceptives are a good choice. Whereas DMPA, POP, and implants are taken as MEC2 because they have a side effect of irregular bleeding itself. But if a patient of heavy or prolonged bleeding, which includes both regular and irregular, comes to our OPD, then combined hormonal contraceptive is one of a good choice. In such cases, the copper intrauterine devices, these implants, DMP, and even the progesterone only pills are taken as MEC2. In a case of endometriosis, again, LNG, IUS, and implants, DMPA, POP, and CSCs, they're all MEC1 except copper IUD, which is taken as MEC category 2. In case of benign ovarian pathologies, all contraceptions are advisable whenever a patient of severe dysmenorrhea comes to us, then combined hormonal contraceptives, LNG, IUS, implants, DMPA, POPs, they all can be used as MEC1, whereas copper IUDs are taken as category 2. So along with other contraception, many have any other benefits. So they can be utilized like LNG IUS now is a boon to many of the patients with dysmenorrhea, with adenomyosis, with menorrhagia, with endometriosis. So it's in a boom and it can offer contraception as well. So whenever a patient of uterine fibroids, they approaches us and they don't have any distortion of cavity, like there's no submucosal fibroids, then all contraceptives can be offered. But when there's a severe distortion of the uterine cavity, then implants, DMPA, POPs, or CSCs are better choice because there may be difficulty in the insertion or there may be improper placement of the intrauterine systems like copper IUD and LNG IUS. When a patient of anatomical abnormalities like a distorted uterine cavity comes to us, it applies the same as with other abnormalities. If a patient of pelvic inflammatory disease had a past history, but at present there's no current risk, all contraceptives are MAC1. But when a patient is suffering from the current PID, then implants, TMP, POPs, and CSCs are far better choices. But if they're using any of the previous intrauterine systems before they encounter with PID, they can continue, but initiation is always taken as category 3. If a patient of HIV infection has, or a patient has a high risk of infection HIV, then all contraception can be given when as far as the patient is not infected. But if it's an HIV infected case and the CD4 count are appropriately more than 200 cell per millimeter cube, the progesterone implants, the POPs, the CSC and DMPA are MAC1, whereas intrauterine systems like copper IUD and LNG IUS are taken as MAC2. If a patient is having a CD4 count less than 200, then again implants, POP, CSC, and DMPA are taken as MEC1. The continuation of intrauterine system can be categorized as MEC2 and initiation is always taken as MEC3. A patient of cervical ectropion, all contraception are advisable, but in a case of CIN, copper intrauterine devices, implants, and POPs are MEC1, and MEC2 is LNG IUS, DMPA, and the CSC. In a case of cervical cancer awaiting treatment, POPs are MEC1, whereas implants, TMP, and CSC are MEC2, and the intrauterine systems are taken as MEC4 and are not recommended. In a case of endometrial cancer, the intrauterine systems are again discouraged. We can offer our patients with implants, TMP, POP, or CSC, and patients with ovarian cancer, copper intrauterine devices, implants, TMPA, progesterone-only pill, and even combined hormonal contraceptives can be offered as MEC category 1. In a case of gestational trophoblastic disease with undetected HCG levels, all contraceptives are category 1. When there's a decreasing HCG level in a proven case of GTN, then CSC, POP, implants, TMP can be taken as MEC1, whereas these intrauterine systems are taken as MEC category 3. If there's a persistently elevated HCG level or malignant disease, then MEC1 category is combined hormonal contraceptives, POPs, implants, and DMPA, whereas the intrauterine systems are highly discouraged or contraindicated in such cases. Because we don't prefer any contraception that can cause abnormal uterine bleeding while the patient is on follow-up. So we have to really counsel a patient well about all the choices we have, and the potential side effects have to be explained in detail before we offer any kind of contraception, be it category MAC1 or MAC3 to 4. We all are aware of the breast diseases and are also aware that breast cancer is a hormone sensitive and the hormonal contraception may cause recurrence. The benign breast diseases, all contraceptives can be given. When there's a family history of breast cancer, all methods are MEC1. But when a patient of current breast cancer reports to us, then copper intrauterine device is MEC1 and all other are taken as MEC category 4. If a patient of past breast cancer comes to our OPD, but there's no disease for the last 5 years, then copper intrauterine devices again are the safest choice and all other contraception are taken as MEC category 3. If a patient of breast cancer but a carrier of BRCA1 or 2, then again copper intrauterine devices are the MEC category 1. The progesterone-only pills, LNG, IUS implants, and DMPA are again taken as MEC2, and the combined hormonal contraceptives are really contraindicated or taken as MEC4. In cases of gastrointestinal diseases like these inflammatory bowel diseases, the copper IUD implants and LNG IUS are the preferred choice because the malabsorption, they reduce the efficacy of all the oral methods of contraception being used. Secondly, the women of IBD, they have a slightly lower bone mineral density, so DMPA should be avoided. In inflammatory bowel disease women, they are also at increased risk of venous thromboembolism, but there are no restrictions for the use of combined hormonal contraception in cases of mild IBD. If a patient of gallbladder disease or history of cholestasis, then again copper intrauterine devices are the safest. The progesterone derivatives are taken as MEC2 and combined hormonal contraception as MEC3. But when it comes to the only history of cholestasis of pregnancy, then all choices can be offered as category 1. In a case of liver disease, we are aware that hormones are usually metabolized in the liver. So whenever there's a liver disease, it will be compromising the liver functions. Secondly, the presence of estrogen receptors in the liver, it is susceptible to damage from the estrogen-containing contraceptives, whereas progesterone-containing contraceptives can be safely used in a case of liver diseases. So when a patient of acute hepatitis or flare comes to us, then POPs, TMP implants, LNG IUS or copper IUD are MEC1 and CSCs are taken as MEC4. If a person is only a carrier of hepatitis or a case of chronic hepatitis, then we can offer all the contraceptives. And a case of malignancy or a liver tumor, copper IUD is the best choice. The progesterone derivatives are taken as MEC category 3 and combined hormonal contraceptives are usually contraindicated. In cases of mild cirrhosis, all contraceptives can be used, whereas in case of severe cirrhosis, only copper IUD is taken as MEC1. In cases again of benign focal nodular hyperplasia or hepatocellular carcinoma, copper intrauterine systems are the best choice. The combined hormonal contraception in all cases are taken as MEC4. And the progesterone derivatives are usually MEC3 in severe cirrhosis and hepatocellular carcinoma, whereas in MEC2 in benign focal nodular hyperplasia. Coming to the immunological disorders and contraception, SLE increases the risk of ischemic heart disease, stroke, as venous thromboembolism. SLE and rheumatoid arthritis with no antiphospholipid antibodies, in that case, copper intrauterine devices are taken as MEC category 1, whereas progesterone-only pills, LNG, IUS implants, DMP, and CSCs are taken as MEC2 and DMP is taken as MEC category 3. If a patient of SLE and rheumatoid arthritis with positive or unknown antiphospholipid antibodies, then copper intrauterine copper intrauterine system is categorized as MEC1. The POPs, LNG, IUS implants, or DMPA are taken as MEC3 and combined hormonal contraception is taken as MEC4. If a patient with SLE and severe thrombocytopenia comes to us, then in such cases, we don't have really much choices as MEC1. The reason being, it may lead to severe bleeding or side effect. The problems can arise. Combined hormonal contraception, the POPs, LNG, IUS, and implants are categorized as MEC2. Copper intrauterine devices, if already a patient is using that, it can continue, but initiation is taken as MEC4. When a patient is having a solid organ transplant, in such cases, progesterone-only pills implants are taken as MEC1. And the intrauterine system's continuation can be continued, but initiation is taken as MEC3. As we all know that obesity is having a rising trend. So a patient with BMI less than 30 kg less than 30 kg per square meter, all the contraceptions can be used. But with a higher BMI, the progesterone-only pills, DMP, implants, LNG IUS, and copper IUD are MEC1, and we should avoid the use of combined hormonal contraception. If a patient is having a BMI more than 30 kg and the age less than 18 years of age, we have to be cautious while using DMPA because we are all aware of the effect of the DMP on the bone mineral density. Obese women are also at risk of thromboembolism and hypertension, so we have to be cautious whenever we are using a combined hormonal contraception. Coming to the miscellaneous category, thyroid disease, all contraception methods are advisable. When a patient of thalassemia, sickle cell, in iron deficiency, we should avoid using copper IUDs in the first instance because after the insertion of copper IUDs, majority of the patients do experience menorrhagia for the initial few months, and hence copper IUDs are taken as MEC category 2. Coming to the postpartum part, in a breastfeeding women 0 to 6 weeks, 0 to less than 6 weeks postpartum, implants, POP, copper IUD, LNG IUS till 48 hours are advisable. But if it is more than 6 weeks and less than 6 months postpartum, excluding combined hormonal contraceptives, all can be used. If the patient is more than 6 months postpartum, all contraceptions are fairly advisable. If a patient is postpartum and is not breastfeeding and is less than 3 weeks and with other risk factor of venous thromboembolism, it is good to avoid combined hormonal contraceptives and DMPA. When the patient is 3 to less than 6 weeks, but with other risk factors for venous thromboembolism, we have to be really cautious while using this DMP and combined hormonal contraception. So if a patient is postpartum more than 6 weeks, there is no indication of any kind of contraception, whether the patient is feeding or non-breastfeeding. Again, many of the things they apply to the post-abortion contraception. In first trimester, all are advisable, whereas in second trimester, the copper intrauterine device and LNG IUS are not advisable immediate postpartum because there's higher risk of expulsion of such devices. Secondly, in a case of septic abortion, we should be vigilant and we should not be using any intrauterine device as a mode of contraception. If a patient is having any history of pelvic surgery or past ectopic pregnancy, all contraceptive methods are advisable. So thank you so much for your patient listening. I hope we had this overview of AI is also providing reproductive health education by the AI-powered awareness platforms. It plays a pivotal role in reproductive health education. The AI-powered platforms are offering personalized information on contraceptive methods, the sexual health, and the fertility awareness. Natural language processing capabilities, they enable the interactive and tailored conversations, fostering a deeper understanding of contraception options and promoting informed decision making. This was one of a publication in November 2023, where they have experimented that AI and a self-managed abortion can ChatGPT provide assistance when no physician is present. So the conclusion was, in its current form, the ChatGPT provides accurate and understandable patient-facing information, although it failed to direct the patients to safe sources for online abortion medication, but it was able to provide the accurate and understandable information regarding the self-managed abortion. So the AI also helps in early detection and the predictive contraceptive health monitoring. By analyzing the health data related to reproductive health, AI algorithms can detect the subtle changes that may impact the contraceptive effectiveness. This early detection allows individuals to make informed decisions about adjusting their contraceptive methods or seeking additional support. A lot of user-friendly contraception apps have developed, and this increases the accessibility and the engagement. By providing the user-friendly interface for individuals and to track and manage their reproductive health. It also offers features such as cycle tracking, fertility predictions, and reminders for contraceptive methods. It also enhances the accessibility and the engagement, encouraging the consistent use and promoting the effectiveness of contraception methods. The Population Foundation of India has created the SNE AI, the first English, that is Hindi and English, AI chatbot in the nation, taking into account social and behavioral trends in India. While offering a concealed, friendly, and comfortable setting to encourage conversation about the taboo subjects, including safe sex and family planning, it gives the factual, practical, and reliable information and resources. SNE AI is an inventive, entertaining, and instructive solution that enables communication and education about the sensitive and important topics for demographic groups that are at risk and hard to reach. It serves as a powerful illustration of the essential potential of AI technologies to advance societal good. About us as the FOGSI Family Welfare Committee. Artificial intelligence and the machine learning app can be instrumental in choosing the best possible contraceptive option for a couple. WHO and UK MEC criteria has been utilized to design the AI-aided apps. Contraceptive checkbox can give the feedback and help in giving advices in special situations. And we, the Family Welfare Committee of FOGSI of the Federation, has launched this artificial intelligence aided contraceptive app in India last year. There are options of the smart contraceptive devices, which can be AI enhanced. The traditional contraceptive devices are evolving with AI enhancement. The smart condoms and diaphragms equipped with AI technology can provide the real-time feedback on the usage, effectiveness, and potential risk. These devices, they offer a more connected and personalized approach to contraception, ensuring users have the information they need for optimal effectiveness. AI also helps in adaptive contraception plans, which are tailored to the individual lifestyles. By analyzing the user behavior, preferences, and the health data, AI algorithm can dynamically adjust the contraception recommendations. And this ensures that the contraceptive plans aligns with the unique need and the preferences of each user, optimizing effectiveness and user satisfaction. So coming to conclusion, online platforms, chatbot, smartphone apps driven by AI can deliver precise and individualized information about contraception, reproductive health, and related topics. This can raise people's awareness, enable them to make wise decisions, and clear general misconception. AI can help the policymakers make decisions by analyzing the complicated data sets, simulating various scenarios, and recommending methods that are supported by the available research. This could assist decision makers in developing policies which are based on the data-driven insights and on well-informed decisions. In order to ensure the effective family planning services for all Indian individuals and couples, future prospects include strengthening healthcare system, raising awareness, enhancing access, and addressing the socio-cultural concerns. Localization is necessary before AI models, methods, and technology are implemented. The opportunities and problems associated to family planning and the population growth, it differs by nation and place due to varying level of facility accessibility and the implementation capabilities to address the issue and potential provided by AI. Before to implementing AI in the family planning, policymakers should thoroughly examine the social, the economic, and cultural issues. And to ensure the successful development outcomes, policies on family planning be linked with policies on the use of AI to population related challenges. So, the take home message: artificial intelligence can be used in many ways to improve contraception, including analyzing the health data, fertility tracking, genetic testing, contraceptive devices, which can be made more smart, reproductive health education, helping in predictive health monitoring, apps, the contraception plans can be tailored as per the individual needs and can help in remote consultations. So, thank you for your kind attention. And what we are doing today is again a very good example of AI powered platform to raise awareness on the occasion of this World Contraception Day. Thank you so much.
Hello everyone, welcome to this lecture. This is actually a lecture where we will be talking about our Family Welfare Committee app. So this is an app which we have launched under the presidency of Dr. Rishikesh Pai sir. Dr. Rishikesh Pai sir and Dr. Ashish Kale sir has been instrumental in bringing about this idea, the very idea of launching this online app on the World Population Day last year. So it is actually an artificial intelligence aided contraceptive app and which has come out to be the first time ever in history of India. It is the most awaited app of today. So when we had launched it, the mastermind behind it was Rishikesh Pai sir, Ashish Kale sir, our committee chairperson, myself. I have been working with them and in cooperation with IIT Roorkee, engineers from IIT Roorkee, we have developed this app. So let us see what this app is all about. So actually, the app was designed first in Android because most of the people in India still use Android phone. But slowly, once we have got it launched on Android app, that is Google Play Store, then we will approach the Apple app also, Apple Store also. So actually, it has used multiple if loops for designing the software. A series of questions are present in this app, and each question has an answer yes or an answer no. So it is very much user friendly. I want to tell at this moment that basically in our contraception at this moment, we have the WHO or the United Kingdom's MEC, that is Medical Eligibility Criteria Wheel. MEC wheel can be read by gynecologists only because others don't have the expertise in reading the MEC wheel. But with this app now, every patient sitting in every corner of the world gets a user-friendly app whereby they can ask questions themselves and get answer regarding what type of contraception is best suited for them. So these questions have been devised or modified from the MEC wheel only, but it is in a very user-friendly and very simple language. So a multiple questions will be asked to the patient in the screen, and the answer, if the answer is yes to each question, then the user will be automatically directed towards the best contraceptive option for her based on the current evidence and literature. But if patient answers no, then it automatically directs to the next question in the series. So the data afterwards will be recorded and saved for machine learning. And there comes the importance of artificial intelligence or machine learning. After that, a contraceptive chatbot is also there, which will help to answer any number of queries which patients have related to contraception rising in the minds of the users. It means, suppose if the machine says that the best possible contraception for you is progesterone only pill, that is POPs. So I hope nobody will understand what is the meaning of progesterone only pill. Everybody will have a question in their mind how are we going to use this progesterone only pill? What are the advantages? What are the disadvantages? What are the contraindications? Should I be using it daily or I have to take at times? What happens if I miss the contraceptive, this POP tablet? So these all questions will be answered by Dr. Bot, which is a contraceptive chat bot which has been validated and checked previously before launching it. So follow-up visit is scheduled after 6 months of the provided contraceptive use, whereby we get feedback and rating from our clients in a scale of 1 to 10. 1 is the worst feeling and 10 is the best feeling after getting the contraception. Artificial intelligence will then determine the most acceptable method of contraceptive for a given patient, particular to a given situation. So this is the multiple if options which are available, and then based on that, various answer keys will be devised. So this is basically the algorithm which people from IIT Roorkee have devised for us. So this is the first page which opens, whereby patient is asked regarding the various particulars. Patient has to fill the name, age, height and weight and confirm when the BMI will be calculated itself by the app. Then the questions come one after the other. Are you an active smoker? Yes or no. Are you nulliparous, or do you have large fibroids in your uterus? Are you experiencing any active unexplained vaginal bleeding? Are you HIV positive or suffering from sexually transmitted diseases? So basically these questions come in series one after the other. If you press yes, then it goes to the most probable contraception for option 1 and option 2 alternative option. And if you press no, then it goes to the next question in the line. So various questions keep on going one after the other. And finally, when all the questions are over, then the machine says the recommended contraception method for you at this BMI with these complaints or these comorbidities will be this. Okay. So then it will ask whether you want to talk to a chatbot for more information. So of course, everybody will want to talk to the artificial intelligence aided chatbot. So it will then take to this page whereby the Dr. Bot will say, hi, I'm Dr. Bot. How can I help you today? So like patient has clicked how to use progesterone only pill. So then the answer comes automatically and patient can get satisfied. Now, what happened with FOGSI when we had presented it in the MCM meeting in Mumbai? It happened to be that Dr. Aparna Sridhar, chairperson of Family Welfare Committee or Contraception Committee of FIGO, had come at that time, and now it has been taken to the global platform whereby FIGO and FOGSI jointly collaborates with each other. And now it is a joint venture of FOGSI and FIGO to make this app a global platform where people from all countries can access it. So the President FIGO has now ensured us that this app will be brought about in various languages. Okay, not only in English. English, of course, is the first version which we are taking about. But for India, we have later on coming Hindi, Marathi, Bengali, Punjabi, and other languages, other Tamil, Telugu, all the vernacular languages will come up. And also we will have it in other languages also, like African people wanted it in African languages, Mexican people wanted it in Mexican languages, French, Spanish, and all languages. As far as we can convert, we can do. FOGSI has also taken the initiative that from our directory, FOGSI members directory, we will also advise the patient the nearby gynecologist in your area within 1 to 1.5 kilometers radius. Patients can visit their gynecologist whom they want to visit based on the phone numbers and names. Whoever they want to visit, they can visit for their further advice related to contraception. So I hope that this very app will be very much user friendly and people will find it very easy to get the best possible contraception for them, and then their doubts will be solved in the subsequent this thing in the same platform only. And after that, this will be the basis of machine learning and future learning. Until now, we have collected data of over 2000 patients, that is clients, and we intend to collect it more and more, because if similar patient comes to us and if they do not like the type of contraception, then machine learning will itself direct the next patient to the second possible option for us. So this is how contraception has now become a dynamic tool, not a static tool. And I think in an era of machine learning and artificial intelligence, of course, contraception should also not be behind. So thank you so much. Thank you for giving me this opportunity. And I thank Ashish Kale sir, our upcoming presidents, and the president now currently, Dr. Jaideep Tang sir, Dr. Sunita Tandulkar ma'am, and everybody. And we hope that by next year, we are going to launch this app. Thank you so much. Hello, everybody. Myself, Dr. Aveer Sarkar, North Zone Coordinator at Family Welfare Committee, FOGSI. Today, I'm going to talk about RISUG, that is RISUG, or Reversible Inhibition of Sperm Under Guidance. So, let us talk about it in detail. So what actually is RISUG? Reversible inhibition of sperm under guidance. This is an unsung tale which we will be talking about today. So basically, when we talk about this RISUG, why was the need to introduce this reversible inhibition of sperm under guidance? Basically, we all know that we have two basic major types of male contraception. One is the barrier method of contraception, which has got a very high failure rate, so we don't advise it. The second is vasectomy, which is quite effective because it has a very low failure rate, but it is an irreversible method. So in our country, males have not taken up vasectomy so nicely. So till date, we don't have any ideal method of male contraception. By male contraception, ideal method, we mean that it should be a long-term method which is effective. It should preferably be a one-time intervention. It should be a minimally invasive drug delivery system with negligible side effects, and option of reversal should be present. But vasectomy is having all these, but option of reversal is not present. So an ICMR funded novel project was brought about by Professor S.K. Guha when he was in IIT New Delhi. Next, he shifted on to IIT Kharagpur. It had successfully undergone multicentric phase 1, phase 2, and phase 3 trials, and now it has the potential of becoming a mass-use injectable male contraceptive because it is easily reversible, a method of long-acting reversible contraception besides vasectomy. So the main advantage of RISUG over vasectomy is that it has chances of reversal. So what is the agent that we are injecting? We are injecting a polymeric agent, which is 60 milligram of styrene maleic anhydride dissolved in 120 micromoles of DMSO, that is dimethyl sulfoxide. So it means it is 1:2 weight by volume. DMSO here acts as the transport medium, and the site of injection is at the lumen of the vas deferens. What is the mechanism by which this acts? Number one, it creates an occlusion effect. So of course, when we inject it into the vas deferens, an occlusion is created. This is because it disturbs the inherent negative electrical surface charge which is possessed by the sperms. Number two, it also causes a charge mosaic, and this charge disturbance causes an imbalance in ion transfer rates, ultimately rupturing the spermatozoal acrosomal membranes. So, although the sperms are there present in the seminal fluid, but the acrosomal membranes rupture, and so they are not able to fertilize. And number three, once the spermatozoa, the acrosome, it lyses, then acrosin and hyaluronidase leach out of the spermatozoal head, and the spermatozoa lose their fertilizing ability. And the acidic pH of the rhizoom also neutralizes or catalyzes the process of neutralizing the alkalinity of the semen. So the seminal fluid is also not having the ability to go and fertilize with the ovum. So once our patient is ready, we go for a pre-procedure client preparation. Of course, we all need to have a gather approach of counseling, which is very much required. Written informed consent is required. Partner consent, as of now, is a question mark, but since it is in the research arena, it is better to take a partner consent. Now, the subject washes his genital area thoroughly with soap and water, dries the area, and then ask him to lie down in supine position on the surgical table. There is no recommendation of antibiotics in rhizoom. Under aseptic precautions, first painting and draping of the pubic area, penis and scrotum and adjacent areas of both the legs near the scrotum is done as shown in the picture. Then the penis is drawn away with a scrotal traction and also a traction on the penis, and we can secure it with the rubber band also with the surgical drape. With a three-finger technique, which is also called the engender technique, locate the ideal entry point. As you can see in the picture, the ideal entry point is the midway between the pinoscrotal junction and the upper pole of the testis along the median raphe of the anterior wall of the scrotum. After that, anesthesia is given, 2% lignocaine is injected with epinephrine into the skin to raise a wheal of 10 to 15 millimeters in diameter. After that, go to both the sides, that is the right and the left. First of all, as most of us surgeons are right-handed, we go to the right vas deferens, and beside the vas deferens, we give a vasal nerve block. That is a anesthetic agent, 2% lignocaine is injected into the external spermatic fascia by palpation to raise a wheal to give a vasal nerve block. Then repeat it in the opposite side. Once you have injected on both the sides with a surgical gauge, gentle pinch is given so that a thin skin wheal is raised. Then the right vas deferens is caught hold with a dissecting forceps, and a 2 millimeter incision is made, and the vas deferens is brought out through the incision with a curved artery forceps. Once the vas deferens is delivered, then without injuring the artery to the vas, you puncture it, and with the help of your needle, the beveled end putting upwards, you try to inject the rhizoom into the vas deferens. Also, with your left thumb, you can prevent the backflow into the testis so that the rhizoom does not flow back. Inject the solution, and with the thumb, apply pressure over the vas deferens for 2 minutes to prevent extravasation. Similarly, do on both the sides, and then allow the vas to slip back into the scrotum. Then after that, after the completion, pinch the scrotal skin for a minute, and you need not to put any suture. Antiseptic cleaning is done with Savlon or betadine, and a band-aid or a tape is applied over the puncture site. And post-procedure, you have to observe your patient for 1 hour only, and that's it. Abstinence is not required for the next 3 days. So you need not to ask your patient to get a repeat semen analysis done. Unlike in vasectomy, you need not to get it done, and you can directly ask your patient to go and start the routine activities of day-to-day life. The best advantage is that it is reversible. So you need to inject 200 to 500 micromoles of DMSO whereby we were injecting 120 micromoles. Now, when we inject the solvent in high amount, it dissolves the residue. Number two, you can inject 5% sodium bicarbonate, which also by its alkalinity nature, it will dissolve the acidic residue by itself. The site of injection is at the level of the vas deferens. This will lead to the extrusion of the residue from the urethra itself. The significant advantages are that it is easily reversible method, high contraceptive efficacy of around 97.9%. So around 3.1% is the failure rate of residue. It is a time control procedure, so restoration of spermatozoa will be there, and that too, even if spermatozoa are present in the seminal fluid, it doesn't have the ability of fertilization. Reversal is there, no changes in hormonal profile, no impairment of sexual pleasure, no discomfort of the female partner, and quick return of fertility following reversal. And of course, it is a method of LARC. So in the basket of long-acting reversible contraception, now we have one male contraception also, which is in the form of Risu. The current status is that it has passed all phase 1, 2, and 3 clinical trials in 6 centers of the country, whereby 300 subjects have undergone Risuk injection till now. The interim data analysis, which was available since 2016 in the ICMR, it had included all people from all religions, all castes, all educational levels, and there was no adverse effect which is observed till now, even after 6 to 7 years post Risuk injection. Luckily, nobody has undergone Risuk reversal till now, but if any case comes out of Risuk reversal, then we will get data on it. So even after 6 years of post-Risuk injection, there has been no change in the blood parameters, CBC, RFT, LFT, blood sugar profile, and urine examination. And 92.6% of the subjects had achieved azoospermia in 2.5 months, whereas it rose to 96.7% at 6 months. But mind you, even if patient is not azoospermic, the spermatozoa do not have the capability of fertilization. So a few dropouts were also there in the study. There were some personal reasons, or subject got transferred to other hospitals. There were family problems or lost to follow up, or the center of the study changed. So of course, it is a ray of hope in male contraception, which is safe and effective, quite good acceptance by all religions in all 6 centers of the country. After being approved by the government of India, it is expected to shortly become a popular method of male contraception among the mass public of the country. So that's all. Thank you so much, and wishing all of you a happy World Contraception Day. We hope that our country also leads in contraception so that we go for population stabilization. Thank you.
So I'll be talking about the newer contraceptives available in the market. Let's talk about vaginal ring. It is available in India since 2009 in the name of Nuva ring. It releases ethinyl estradiol 15 microgram and etonorgestrel 120 microgram daily. It is a circular and flexible ring made of diethyl polysiloxane. Unlike vaginal diaphragm, it does not have to be in a specific position in vagina. The failure rate is very low, 0.3 to 0.6 pregnancies per 100 woman years. Now, the ring is placed by the woman herself, just like a tampon insertion. It is placed in the vagina for 3 weeks and removed for 1 week. Withdrawal bleeding occurs in the ring-free week, and it is followed by the insertion of a new ring. It can be removed during intercourse daily for 3 hours. If the ring is out of vagina for more than 3 hours, a backup contraception is needed for next 7 days. Now, what are the advantages of vaginal ring? It has a high rate of efficacy, about 99% effective. It reduces the cramps and acne, helps to regulate periods. It is a reversible method. Non-daily dosing schedule is there. It is relatively low drug doses and higher user acceptability. Now, the disadvantages are that there is increased vaginal discharge, involuntary ring expulsion during sexual activity, straining on the toilet, and removing tampons. It needs to be inserted every 3 weeks. The contraceptive ring can be affected by some medicines such as antibiotics, antifungals, and other medications. It does not protect against STIs, and the discomfort may occur during insertion and intercourse. Now, we'll talk about contraceptive patch. It is not available in India as for now, but it is US FDA approved in the name of Ortho-Evra. The birth control patch is a prescription medication, and risks associated with its use are similar to those of oral birth contraceptive pills. It is a small square patch that can be composed of several layers. The hormones estrogen and progesterone are usually located in the lower adhesive layer. The layer is placed directly in contact with the skin, and the synthetic hormones are directly released into the bloodstream and interfere with the woman's normal menstrual cycle. A single patch can be worn for 1 week before it needs to be replaced. It should be replaced on the same day each week for 3 weeks in a row. The patch is not worn during the 4th week, at which the time woman will have her menstrual cycle. Now, as I've already told, it is available in US in the name of Ortho-Evra, 0.75 milligram ethinyl estradiol and 6 milligram norelgestromin, an active metabolite of norgestimate. Evra also is available in the composition of 0.6 milligram ethinyl estradiol and 6 milligram norelgestromin. Now, the mode of action is it suppresses the ovulation similar to OCs, and the follicular development is also hampered. It reduces cervical mucus pores, and it makes the cervical mucus more hostile to sperm penetration. It induces progestational endometrium and reduces the endometrial thickness. Now, it has 3 separate layers. The lower one is light brown, flexible, 4.5 into 4.5 centimeters. The middle is an adhesive, which contains the active hormones. And top one is protecting the adhesive layer and removed prior to application. Now, it can be placed on 4 sides, the upper torso, excluding the breasts, or on the upper outer arm or lower abdomen or buttocks. Now, the 2 consecutive patches should not be placed over the exact same area. The hormonal absorption from the lower abdomen is 20% lower than that from the upper parts. Now, once a week daily schedule is there. One patch is worn for 1 week for 3 weeks, followed by a patch-free week. The first patch should be placed on first day of the menstrual cycle. If a patch change is missed for 2 days, clinical efficacy is maintained and a backup contraception is not needed. Now, when it can be initiated after childbirth in a female who is not breastfeeding, she has to wait for 4 weeks. A backup contraception is used for 7 days. After first trimester miscarriage, immediately it can be used on the same day, and a backup contraception is not necessary if the patch is started within 5 days. Now, pharmacokinetics of Ortho-Evra versus OCPs is that it contains a higher level of ethinyl estradiol, and it is about 60% higher, and a lower ethinyl estradiol peak concentration is there in 25%. No significant difference is there on coagulation factors. Now, the side effects, there is an increased risk of venous thromboembolism, and it is about 40.8 per 1 lakh women a year in case of patch and 18.3 in case of OCPs. Now, the most frequent adverse effect is headache and nausea. Some females may experience discomfort and breast engorgement and pain, more with the patch than OCs during first and second cycle. But once the patient continues with the patch, there is almost nil breast symptoms during 16th or 13th cycle. Now, dysmenorrhea occurs in 13.3% patients using the patch as compared to 9.6% in case of OC users. Breakthrough bleeding is also low and similar to that of other oral contraceptive pills. Now, application site reaction may be mild or moderate in 20% patient, and there may be discontinuation due to this in case of 2.6% patients. Now, there may be changes in the weight. It is minimal use for 13 cycles, then 2.2% patients, there was weight gain of 10%. In 1.4% patients, there was weight loss of 10%. So it was comparable to other OCs. So the contraindications are identical to those of other oral contraceptives, except active skin conditions which could alter the rate of hormonal absorption, or dermatological conditions that would be worsened by patch application. On the other hand, patches are used when pills cannot be used, example, GIT absorption problems. Now, European multinational study in 2011 states that there is a high level of women's satisfaction, emotional and physical well-being, and compliance with transdermal contraceptive patches, and there is also improvement in premenstrual symptoms. So compliance is better with patch as compared to OCs. It is 89% in cases of patch as versus 79% in other oral contraceptives. Now the efficacy, overall method failure is only 0.4% and user failure is 0.1%. It is highly efficacious and similar to other oral contraceptives, but it is less effective if the patient is obese and the weight of the female is more than 90 kg. So we can conclude by saying that the transdermal contraceptive patches, as compared to other oral contraceptive pills, are similarly efficacious and have similar adverse effects, but there is higher satisfaction and compliance, and it is easy to use, especially in working females who cannot remember daily dosing of OCPs. So it is quite easy for the patient to carry and apply, because it does not require any technical support from doctors or any assistance from the nurses to put the patch. So it is more suitable for today's active lifestyles. Thank you for patient hearing.
Hello, greetings on the World Contraception Day 2024. So the topic is lactational amenorrhea method, LAM. LAM, as we all know, is a natural family planning method for breastfeeding women. So when we are talking about this, it is a family planning method based on the hormonal suppression of ovulation caused by breastfeeding. And it is easily visible here in this picture, how the brain is affecting this whole loop. So let us see this. The physiology says that mechanical stimulation of nipple is happening. Neuron signals are sent to the hypothalamus. It changes the level and the rhythm of GnRH released by hypothalamus to pituitary, which in turn is acting on FSH and LH. So we are seeing decreased and disorganized follicular development. As we have gone through the physiology, now LAM has a criteria. So there are 3 points and all 3 must be met. First of all, it is exclusive or almost exclusive breastfeeding. Periods have not resumed. Baby is less than 6 months old. So as I said earlier, all 3 criteria must be met for a woman to be eligible to use LAM. So as you see, breastfeed exclusively or almost exclusively. Exclusive breastfeeding means that baby is not being fed any other liquid or solid. However, if baby is being given, vitamins or maybe, water which is replenishing minerals which are lost in the baby, or any ritualistic feed, then we are talking about almost exclusive. And here there is another thing also, when we are taking the history, we have to see whether it is exclusive, almost exclusive, or sometimes, women are only for minimal or occasional or irregular breastfeeding. And they take great pride in saying that it is about the breastfeeding. And if it is a partial breastfeed, we have to say what is the proportion of the breastfeed and the artificial feed that is being given to the baby. Majority, it is the breastfeeding, or the breastfeeding part is quite low and the artificial fed part is more in that particular baby. So that is about the point 1, exclusive breastfeeding. Then your period should not have resumed. And there is the criteria, this also. So with these 3, contraceptive efficacy is reported to be 98% effective. Now, this was a clinical trial which was done in 1997 and which shows the data out here. So In this, I usually tell in my clinics that it gives you a 98% effectivity if you meet all the 3 criteria. But that also means that out of 2 out of 100 women, in that case, this will not be effective. And I do not know that you lie in the 98% or the 2%. This is what the gynecologist should counsel. Now, advantages of LAM, all of us know that it protects from pregnancy. Yes, unwanted pregnancy, promotes good breastfeeding behavior. We'll see it further how it can be an introductory family planning method. So then they take up the further family planning methods with they take quicker decisions for that. It's good for the health of the baby and the mother, easy to train, teach, and use, and can be offered by different type of providers, and no commodity is required for it. So if we're seeing this, you put up the 3 things, right? The 3 criterias, and then you see that if she giving her baby any other food or liquids or allowing more than a 4-hour gap between the feeding, 6 at night, okay? So no and yes. If the answer to all 3 questions is no, then LAM will protect the woman for a pregnancy. If not, even if in one she's putting yes, then LAM will not protect the woman from the pregnancy. So then LAM criteria, when we talk about the exclusive breastfeeding, so if, if she's giving her any other food or liquids and the baby will become full and not want to drink breast milk as often, she'll not produce as much breast milk. Infrequent stimulation of the breast will make her fertility return according to the physiology as we've already seen, right? So that means she's more likely to ovulate. Then, as I talked earlier, that exclusive breastfeeding. So exclusive breastfeeding means that do not go more than 4 hours without breastfeeding. In night, it can be 6. Continue to breastfeed even when you or your baby is sick. Do not use bottle pacifier or other artificial nipples, and give the baby all the breast milk that the baby can take. As far as we're talking about the menstrual cycle, so if the menstrual cycle has returned, she's fertile again and can get pregnant. However, the catch point here is that bleeding in the first 2 months after delivery is not counted. Baby under 6 months. So she should continue to breastfeed even though it will no longer prevent pregnancy after 6 months. Her fertility will return. But at the same time, when we're talking about this age limit, so what is happening is, after 6 months, usually baby requires extra nutrients, which will be given. So it will not be exclusive breastfeeding. That means that physiology of, nipple stimulation, deficit gillette suppression will not be that much effective. So that is all about the lactation amenorrhea method. Let us use the contraception that we have and make this World Contraception Day a memorable one. Thank you.
Hello, everyone. This is Dr. Chandrachur Konar. On behalf of the FOGSI Family Welfare Committee, I would like to thank Dr. Ashish Kale, Dr. Ashwini ma'am, Dr. Priya ma'am for giving me the chance to talk about a topic on this World Contraception Day. So my topic today is history of contraceptives, an overview of the evolution of contraceptive methods, introduction to the key milestones in birth control from ancient till the modern times. So ancient practices included herbal remedies, vaginal pessaries, and withdrawal methods. For instance, ancient Egyptians used a mixture of honey, acacia leaves, and lint as vaginal suppositories. Contraception in Egypt and Mesopotamia. So the earliest records show the use of rudimentary contraception as far as 1850 BC. The Ebers Patricius describes several herbal contraceptive methods used in Egypt. And Mesopotamians also practiced birth control using animal intestines as primitive condoms. So about the condom, the first documented use dates back to 1600s, but the version existed as early as 3000 BC. Initially, it was made from materials like animal intestines or linen. In 1844, Charles Goodyear's invention of the rubber revolutionized the condom production. About the pill in 1950, Gregory Pincus and John Rock developed the first oral contraceptive pill. It became widely available after the 1960s, giving women more control over reproduction, and it helped to ignite the sexual revolution and led to significant social change. The IUDs date back to 1909 when Richard Richer invented the first IUD. The modern IUDs use copper or hormonal components to prevent pregnancy. Benefits include long-term protection and non-daily usage. So about Margaret Sanger. Margaret Sanger is a key figure in the fight to legalize birth control in the early 20th century. Founder of Planned Parenthood and a leading advocate for women's reproductive rights, Sanger's efforts led to the widespread acceptance of legalization of birth control. And she's also known as the mother of birth control for her work in legalizing contraception. The modern contraceptive methods from the 20th century onwards, they saw a rise in options like hormonal pills, implants, patches, and emergency contraceptives. Use of male and female sterilization for permanent contraception was also advocated. The rise of hormonal methods for both men and women alongside research into new technologies. So key legal battles in the US and globally for the right to access birth controls are always on the run. The role of the 1965 Gerswald versus Connecticut case, which ruled that married couples could use contraception. So about the future, emerging technologies include the male contraceptive pills, hormone-free options, and long-lasting implants. Focus on improving access in underdeserved communities, the ongoing battle for reproductive rights and healthcare. So this is in brief about the history of contraceptives. I would like to thank the entire FOGSI Family Welfare Committee for giving me this opportunity, and I wish them continued success. Thank you.
Hello everyone, I am Dr. Balpreet Kaur, member FOGSI Family Welfare Committee. On this World Contraception Day, I will be speaking on emergency contraception. So I'll just share my screen. This news has made the headlines on the front page of one of the leading newspaper of the country in the recent past, saying, India is now home, Earth is now home to 800 crore people, and India emerges to be a top contributor over the last decade, adding 17.7 crore to the world population. UNFPA estimated that from 2015 to 19, there were 121 million unintended pregnancies globally, and 48% of the pregnancies were unintended or unplanned. World Population Report 2022 says that India faces a silent crisis of unintended pregnancies, with 1 in 7 such cases worldwide, they occur in India. Now, these pregnancies, they result either from contraceptive failure or from high unmet needs of contraception. Women, those who have unintended pregnancies, they decide either to continue this pregnancy since they have conceived and now they have no choice, or they resort to abortions which may be legal or illegal. Nationwide Survey 2015 says that India registers 16.4 million abortions a year due to unintended pregnancies. And UNFPA reports that unsafe abortions range from 45 to 78% across different states of the country. Now, what are the reasons for contraceptive failure? Miscalculation of infertile days, failed coitus interruptus, expulsion of IUDs, slippage or breakage of condom or the diaphragm or cervical cap, failure of spermicidal tablet or film to melt before the intercourse. These are some of the reasons. Then if a patient is on oral pills, she may have missed the pills for more than 3 days, or she is late for the injections, that is DMPA injections or NEC-10 injections. Then after voluntary sexual act without contraceptive protection, that may lead to contraceptive failure. That can be another reason. And in the event of sexual assault, also the failure can take place. Now, when contraceptive failure takes place, how it is to be managed? Now, immediate before the pregnancy is established, one can go for emergency contraception. Once the pregnancy is established, medical termination of pregnancy is the option. Emergency contraceptives are referred to backup methods of contraceptive emergencies, which can be used within first few days of the contraceptive failure. They are referred to as interceptives because administration of contraceptive after unprotected intercourse or contraceptive failure, it is being given to the couple before the implantation of the embryo, hence interceptives. Now, there are two types of emergency contraception. One is oral pills and another is the intrauterine devices. Oral pills, they have combined oral pills, and there can be high dose progesterone only pills. Then there can be selective progesterone receptor modulators in the form of mifepristone and ulipristal acetate. These pills are also referred to as morning after pills or postcoital pills. Then second option is the intrauterine devices, that is the mechanical methods of emergency contraception. Now, combined oral contraceptive pills, this is the standard method, which contains ethinyl estradiol and levonorgestrel. So, mechanism of action of these combined pills is that they give a negative feedback to the anterior pituitary, inhibits FSH-LH from the anterior pituitary, and thus inhibits ovulation. They cause thickening of the cervical mucus, thus barring sperms to enter into the uterine cavity. Then they make the tubes and the endometrium out of phase and thus inhibits implantation. Now, combined oral contraceptives, when they are being used as emergency contraceptives, it is referred to as a Zeus pills regime, where you can use low dose pills or the high dose pills. Low dose pills, they contain 30 microgram of ethinyl estradiol and 0.15 milligram of levonorgestrel. So 4 pills are to be taken start, and 12 hours later, repeat dose is to be taken. If the high dose pills, that is 50 microgram of ethinyl estradiol and 0.5 milligram of norgestrel is being used, then 2 pills are to be taken start and then repeat dose after 12 hours. So although this is a standard method, but it is not very popular nowadays, the success rate is 85% because they can be taken up till 5 days of the unprotected intercourse. But as the time increases, the coitus to treatment interval increases, the failure rate also increases. Also, there is high incidence of nausea and vomiting in up to 20% of the users. Breast tenderness, headache, dizziness, there are other side effects. These pills are relatively unsafe in women with coronary artery disease, cardiovascular disease, CA breast, and in jaundice cases. So, although it is a standard method, but it is gradually withdrawn. Then currently in India, we are using levonorgestrel pill. It is a second generation gonane. It was introduced by WHO in 1998 and it is US FDA approved. So under the National Reproductive and Child Health Program, the DCGI has approved only levonorgestrel pills to be used as emergency contraceptive pills. Mechanism of action, they interfere with the process of ovulation and they prevent the sperm and the egg from meeting. So the mechanism of action also depends on the time of administration of the drug with respect to the menstrual cycle. So if it is taken before the start of LH surge, it retards follicular growth, delays or inhibits ovulation. If it is taken in the peri or the post-ovulatory period, LNG does not affect corpus luteum function and endometrial morphology. Then studies have shown that LNG has no histological or biochemical change in the endometrium. Now, this is the easy pill. It is available free of cost without the prescription from the registered medical practitioner, and the doses, it is containing one tablet, 1.5 milligram. It is DCGI approved and it is introduced in National Family Welfare Program since 2003. So women of all age group, they can have access to the easy pill or the emergency contraceptive. Now, what is the dose and mode of administration? So, in the event of contraceptive failure or in case of unprotected intercourse in the fertile period, levonorgestrel 1.5 milligram can be taken as a single dose, or if 0.75 milligram dose is available, then two doses are to be taken 12 hours apart, but within 72 hours of the act. Now, in case a woman is weighing more than 70 kg or her BMI is more than 26, then double dose of LNG should be considered. 3 milligram oral LNG is for the patients, those who are concomitantly taking CYP enzyme inducers in the form of rifampicin, carbamazepine, or phenobarbital. The pill should be taken as soon as possible, preferably within 72 hours, but the benefit can be extended till 5 days of the unprotected intercourse, but the efficacy will decrease. Now, in case vomiting occurs within first 2 hours of administration of the drug, the dose has to be repeated. Now, the success rate is measured in terms of time of drug administration. So, if the drug is taken within 24 hours, the success rate, that is the prevention of pregnancy, is seen in 95% of the couples. If it is taken within 25 to 48 hours, then the success rate is 85%. And if it is 49 to 72 hours, then success rate drops to 58%. So failure rate, if it is taken well within the time, is up till 1.8%. Then clinical trials were conducted to compare the efficacy of single versus double dose regime, and it was found that single dose regime is simpler. It is at least as effective as the double dose regime, and there is no difference in the side effects. ACOG also recommends 1.5 milligram single dose regime. Coming on to ulipristal acetate, it is selective progesterone receptor modulator, which is currently not available in India, but outside it is being used and the dose is 30 milligram. Half-life of ulipristal is 32 hours and action lasts for up till 5 days. It can be taken up to 5 days of the unprotected intercourse, but sooner it is taken, the better it is. Mechanism of action. Now, ulipristal, it binds to the progesterone receptors in the ovaries and it stops the LH surge and thus delays ovulation by approximately 5 days. Then on tube and endometrium, the action is debatable, but according to the researchers, it has an antagonistic action. Therefore, it causes too quick transportation of the embryo into the uterus and it causes changes in the tubal secretions. It also causes delay in the endometrial synchronization, and collectively there is inhibition of implantation and or nidation of the embryo. Then clinical trials were conducted comparing ulipristal with levonorgestrel as emergency contraceptive, and it was found that when it was used within 72 hours, then ulipristal has a pregnancy rate of 1.2%, while LNG has a little higher pregnancy rate up till 2.1%. Ulipristal is more effective between 72 to 120 hours after the unprotected intercourse than other emergency contraceptives. Then another trial was taken up and they found that ulipristal acetate can be taken even when the LH peak has started. So it acts at that level also, and it can significantly delay follicular rupture, which is not seen in case of levonorgestrel. Levonorgestrel is to be taken before the start of the LH peak. So henceforth, ulipristal is found to be superior to LNG in inhibiting ovulation near the LH peak. Then mifepristone. Mifepristone, it is a derivative of norethindrone. It has anti-progesterone action. We all know that. It acts as a abortifacient when it is taken in the dose of 200 to 600 milligram. But when a dose is reduced to 10 to 25 milligram, it is used as an interceptive. Mechanism of action, the effect of mifepristone, it depends on the dose and the time of administration. When it is taken in the follicular phase, it delays or inhibits the LH surge, thus inhibiting ovulation. If it is taken immediately before ovulation, it inhibits endometrial development significantly. It also hampers the expression of endometrial markers for receptivity necessary for implantation. Now, large trials have been conducted to find the minimal efficacious drug dose with minimal side effects. And they found that lowering the dose of mifepristone from 600 to 10 milligram, it did not decrease the effectiveness of the drug. No major side effects were noted with different doses, but higher doses of mifepristone, it adds to the treatment cost and it can also cause delay in the next menses. A dose of 10 milligram is found to be sufficient as emergency contraceptive, and it should be given as soon as possible, although the method can be used effectively up to 5 days of unprotected intercourse. Then trials were taken up to compare the effectiveness of mifepristone with standard regimes, and they found that it is superior to the Zeuspi's regime in terms of failure rate and side effect profile. Increasing the coitus to treatment interval was associated with contraceptive failure in Zeuspi's group. However, no such association was seen with mifepristone. Mifi and levonorgestrel, they do not differ in efficacy, and delay in menses with mifepristone did not decrease patient acceptability. Coming on to safety of emergency contraceptive pills. Now, mild side effects are noted with the oral pills in the form of nausea, vomiting. There can be menstrual disturbances in 10 to 15% of the women. They can have periods 2 to 3 days earlier or later than the expected date. Irregular bleeding or spotting can occur in the first week of use. Headache, dizziness, fatigue, breast tenderness, it is not common and it does not last for more than 24 hours. So side effects are not common, they are mild and will normally resolve without further medication. These drugs, they are contraindicated in case of acute porphyrias, pregnancy, if it is there, in severe arterial disease, in cases of undiagnosed vaginal bleeding, if there is history of breast cancer within the last 5 years. Now, as I have already told, if vomiting occurs within 2 hours of taking the drug has to be repeated. Routine use of antiemetics is not recommended. In case of another episode of contraceptive failure or unprotected intercourse is there, then emergency contraceptives can be taken again in the same cycle. The drugs used for emergency contraception, they do not harm the future fertility, and there is no delay in the return of fertility after taking emergency contraceptives. In case the periods are delayed for more than 1 week, then possibility of pregnancy should be ruled out. In case of acute pain or lighter bleeding than the usual menses, then ectopic pregnancy should be excluded. But otherwise, the incidence of ectopic pregnancy does not increase because of emergency contraceptive use. Coming on to mechanical methods, that is the copper T. Copper T is used since long from 1970s and it is WHO recommended. It prevents fertilization by inhibiting sperm motility and affecting sperm viability. It causes a sterile foreign body reaction in the endometrium and it prevents implantation. Failure rate is very, very low, 0.1%, and it is highly effective if it is placed within 5 days of unprotected intercourse. And in some studies, it was used as many as 10 days later, and it was found to be effective. Nowadays, we are using copper T380A or multi-load. Now, MEC criteria, it is preferred in women who desire IUD as a long-term method of contraception. Advantages is that it is a long-term method of contraception. And after 72 hours of unprotected intercourse, it is found to be most effective means of contraception. Efficacy is not affected by the body weight, and it is preferred in overweight and obese women where oral emergency pills may be less effective. Side effects: it causes irregular bleeding, and it accounts for 10 to 15% of IUD removals. Then pain is found to be in 15 to 40% of the cases. Expulsion is seen in 12 to 20%. Then pelvic infection, it is 2 to 8 times more than the non-IUD users. Perforation is seen in 1 in 1,000 women. Ectopic pregnancy, rare 0.2%. Then copper IUD insertion is contraindicated in case of pelvic inflammatory disease, if there is undiagnosed vaginal bleeding, if there is suspected pregnancy, if there is a uterine anomaly which is distorting the cavity, and in case of sexual assault, because the woman is at risk of STI then. Then Cochrane Review has done a study to find out the comparative effectiveness of different contraceptive pills, and they found that LNG and low-dose mifepristone is more effective than Zeuspi's regime. Mifepristone is more effective than LNG, and ulipristal is more effective than LNG. LNG has lesser side effect as compared to combined oral contraceptive pills. LNG users, menstrual return is found to be before the expected date, whereas menses return after the expected date in case of ulipristal users. Menstrual delay is seen in mifepristone as well, and it is dose related. Then copper IUD may be associated with higher risks of abdominal pain than emergency contraceptive pills. So to summarize, the progesterone only pills, that is the levonorgestrel, it is to be taken in the follicular phase and to be taken within 72 hours of the unprotected intercourse and before the start of the LH peak. Whereas anti-progesterone pills, that is ulipristal acetate and mifepristone, they can be taken as up till 5 days of the unprotected intercourse, and they can be taken near the LH peak as well. Copper IUD have an extended action, and they can be taken preferably within 5 days of the unprotected intercourse, as late as 10 days also, and they provide a long-acting, they serve as long-acting method of contraception. Now, when and how to shift to the regular contraception after the use of emergency contraceptives. So if the woman has gone in for copper IUD as a method of emergency contraception, then no additional method is needed. In case levonorgestrel or combined oral pills are used, then any contraceptive method of choice, including copper IUD, may be started immediately. If ulipristal acetate or mifepristone was used, then copper IUD can be inserted immediately. Progesterone containing methods to be started on 6th day of emergency contraceptive. One thing the couple should be told is that methods of emergency contraceptive, they do not protect against STIs, and it should not be used as a regular contraceptive method. Take home message: within 72 hours of contraceptive failure, levonorgestrel pill works best. Copper IUD between 72 to 124 hours of unprotected intercourse. Hormonal emergency contraceptives, they have no risk to an established pregnancy or to the developing embryo. They do not increase the risk of ectopic pregnancy. They do not affect future fertility, and they do not prevent STIs. Regular methods of contraception can be resumed immediately after taking emergency contraceptives, except COCs and POPs, which can be started after 5 days. Women having pregnancy as a result of contraceptive failure is entitled for MTP. Patient education about emergency contraceptive in case of contraceptive failure, it should be promoted. Thank you.
Good morning, everyone. I extend my heartfelt gratitude to all the members of FOGSI Family Welfare Committee for having this Contraception Mandate 2024 on the occasion of World Contraception Day. I would be talking on intrauterine contraceptive devices, a long-acting reversible contraception. So IUCDs are an effective contraception, can be used for an extended period, and does not require user action. So it is also called as one of the forgettable methods. The typical use pregnancy rate being as low as less than 1%, and therefore it is very effective and also among the safest methods of contraception. Advantages being long acting, convenient, cost effective, as well as reversible. It is a reversible birth control device where we place a device inside the uterine cavity for the purpose of contraception. Now, IUCDs have a long history starting from the inert or the first generation ones, which were non-medicated, and the popular ones being the second generation or the copper releasing IUCDs, like the multi-load or the copper T380A. The hormone releasing IUCDs being the third generation, where levonorgestrel intrauterine system, LNG-IUS, is very popular. The fourth generation ones are also upcoming, where we have the frameless ones like the copper or the LNG containing devices. The mechanism of action of IUCD is production of intrauterine environment that is supposed to be acting as spermicidal. So if we talk about the copper containing IUCDs, the copper in the IUCD will cause chemical and cellular change in the endometrium, leading to contraception, and also will increase tubal motility, prevent the passage of sperms or ascent through the thick, hostile cervical mucus caused by copper, and also can prevent implantation through enzymatic interface. Let us talk about the copper containing or the copper releasing IUCDs, like the copper T380A. It has a basic structure of polyethylene frame with barium sulfate impregnated. There is a T-shaped frame, and this barium is for the opacity of the copper device under X-ray examination if required. So it contains 314 millimeter square area of fine copper wrapped around the stem. The stem is the longitudinal part, whereas the horizontal bracelet has copper of 33 millimeter square on each side of the arm. So the total is 380 millimeter square of copper in the total surface area. Insertion is by a typical withdrawal technique, and this device releases copper at 50 micrograms per day, and it is effective for 10 years. This particular copper tea is supplied free of cost by the Government of India under the National Family Welfare Program, National Family Planning Program. The multi-load copper-containing devices are also made up of polypropylene, but here the copper is wrapped around the vertical shaft only. There are two arms made up of flexible plastic with serrated fins, but they do not have copper. The multi-load copper 375 has a lifespan of 5 years and contains 375 millimeter square of copper surface area. In multi-load devices, the vertical shafts are radio opaque, whereas the arms are radiolucent. These are available in sterile packs and preloaded special inserters for insertion high up in the uterus and leading to less chances of expulsion. Now let us discuss about the IUCD timings of insertion. It can be inserted at various periods. The most popular being the interval insertion at least 6 weeks after parturition or an MTP or an abortion. Even during lactational period, IUCDs are very good because they do not affect lactation. So it can be used. Post-abortal period is when we insert the IUCD immediately at the end of evacuation of a uterus, either both by a medical termination of pregnancy or a spontaneous abortion. This must be inserted only after ensuring that the uterus is empty. And the other timing where we can insert IUCD is immediate postpartum or post-placental insertion. Here we require a large and long sponge holding forceps or a Kelly's forceps to insert copper tea near the fundus. Now the last is the post-coital insertion, where the copper devices can also be used as an emergency contraception up to 5 days after unprotected coitus. Technique of insertion of copper T380A is typically called as a no-touch insertion technique. Here, no sedation or anesthesia is required. We load the copper T inside the inserter while still both parts being inside the sterile package. We clean the cervix with antiseptic solution before IUCD insertion to avoid sepsis and also avoid touching the vaginal wall or the speculum blades with either the uterine sound being used or the loaded IUCD inserter. Passing the loaded IUCD inserter only once through the cervical canal should be our aim and the motive. After extensive counseling, written informed consent, the IUCD is inserted under all age-appropriate precautions using the no-touch technique, as you can see in the picture. A basic prerequisite is doing a bimanual pelvic examination to ascertain the size, direction of the uterus prior to insertion of IUCD to avoid complications. Again, we should note the uterocervical length prior to insertion using either a uterine sound or if we have a ultrasonography. Information given to the client is very important. Once you have inserted the IUCD, you need to counsel, and this is for better continuation rate of IUCD and better experience. So we must counsel that she can expect some amount of cramping for a day or two after insertion. So it would be a good idea to give few painkillers at the time of discharge, or vaginal discharge can also occur for a few weeks after insertion. She might have slightly heavy menstrual period with possible bleeding between menstrual periods. Now, this can again be taken over by a very good counseling and explaining to her that this would again wean off after few cycles. Follow-up visit should be scheduled after the next menstrual period to ensure that IUCD is still in place and has not been expelled during the menstruation and that no infection has developed. We should also inform the client about the kind of IUCD which we have inserted and also when to have her IUCD removed or displaced, like the life span of the IUCD. Now, these are very important counseling pointers where we should explain her when to come to the doctor after she has had a IUCD inserted. The first visit is after the immediate next menstrual period, but then again, if she has had any time a missed menstrual period or a lower abdominal pain, vaginal discharge or fever indicating sepsis, or if the thread is missed of the IUCD, or if she has had a very heavy or prolonged bleeding that is bothersome. In all these conditions, she should consult a doctor. We should also advise emergency contraception as backup if IUCD has expelled or misplaced at any point of time before coming and seeing the doctor. There are few complications of IUCD, though rare, but should be kept in mind, like the early ones being the vasovagal attack or the syncope during insertion, or spasmodic pain can occur, which can be easily taken care of by a painkiller or antispasmodic agent. Uterine perforation being very rare, 1 in 1,000 insertions. There are few late complications like excessive discharge, PID, lower abdominal pain, pelvic pain, dysmenorrhea, menstrual dysfunction, anemia, etc. Now, the menstrual dysfunction is again needs to be counseled, that it is usually because of the increased production of plasminogen activating enzymes, as we know, induced by copper of the copper T device. This can cause lysis of the fibrin clot. Also, copper leads to increased endometrial vascularity and hormonal asynchronization, all of which can be expected to fade after few cycles of post-insertion of IUCD device. There are few late complications like ectopic pregnancy. IUCD users, as we should know, are 50% less likely to have ectopic pregnancy than those who don't use any contraceptive method. But however, if pregnancy has occurred with IUCD in situ, then ectopic chances are quite high. We must rule out ectopic as high as 5 to 30% as compared to the general population. The next late complication being the expulsion of the device. Around 3 to 8% of women complain of this, and it mostly occurs during menstruation. A very important complication or a condition is misplaced thread or a missing thread of IUCD. There are very benign causes for it also, like there can be curling of the thread inside the cervical mucus or the uterus, where the thread and the device is intact, but the thread cannot be seen due to curling. The next ones being the expulsion of either the entire device or only the thread has expelled, whereas the device is still inside the uterus. Also, pregnancy can be considered if there has been a missed thread or a rarely uterine perforation. So, sounding of the uterus and ultrasonography can help us localize the IUCD and also ascertain the cause of missing thread or misplaced IUCD. Uterine perforation, though uncommon, but is a serious complication occurring in less than 1 in 1,000 insertions. Majority occur during insertion. So occasionally it can be partial or rarely complete perforation. It can be ranging from no symptoms at all to a sharp abdominal pain or vaginal bleeding post-insertion. So we should be mindful. Diagnosis should be done by a proper clinical examination and ancillary investigations like X-ray, ultrasound, or hysterolaparoscopy. It should be managed properly. If the device is known to be there still inside the uterus, can be removed by a uterine curette or a artery forceps. Gold standard would be under hysterosonographic guidance, or sometimes laparotomy might be required if intestines are thought to be involved in the perforation, etc. This is an ultrasound image of an IUCD in its natural habitat, which is inside the uterus, as you can see, whereas on the picture on the right side shows an embedded IUCD. There are few indications of removal of IUCD where we would want to remove the IUCD where there has been a significant abnormal uterine bleeding not responding to medical management, when there has been acute pelvic inflammatory disease which endangers the life of the woman and the IUCD as a culprit needs to be removed. Missing thread, or when there has been either a perforation or a partial expulsion of the device. Pregnancy has occurred with the IUCD in situ, and also the very common indications being whether she wants to conceive next, so she wants a removal of the device, when the fertility would return immediately, and also after lifespan of the device has got over. Also, if she has used the IUCD post 1 year after the onset of menopause, then she need not require it for contraception, so we should remove it. Thank you so much.
Good evening, everyone. Our President, Dr. Jaideep Tang sir, our Secretary General, Dr. Madhuri Patel ma'am, our Vice President, Dr. Nirja Bhatla ma'am, our Chairperson of Family Welfare Committee, Dr. Ashish sir, and our conveners, Dr. Ashwin Kale ma'am and Dr. Priya Gupta ma'am, and one and all who is present, and all the members of Family Welfare Committee. I am greeting you all from bottom of my heart. Today I am going to discuss postpartum IUCD. Postpartum IUCD is very safe and very effective method of LARC. Although it has greater expulsion rate is 10%, but retention rate is 90%. We have to focus on that only. So, postpartum period, we all know that it starts just after the birth of baby till the 6 weeks of the 6 weeks of the delivery. But this is the period where we can take the advantage of immediate postpartum period for counseling on family planning, on IUCD insertion, because most of the women in labor pain, they decide not to be pregnant again in near future, or to keep a spacing, or not to have another children in life already, or those who have completed their family, they decide not to have any more. And it is very essential that our populations should be checked. And this is the best period where we can counsel the patient just in the last antenatal period, last weeks of antenatal period, or in early labor, or at the time of admission, or during cesarean, just before cesarean, or any time of labor, or just after the delivery. We can counsel the patient to for to have postpartum IUCD as a we can offer them to accept this as a very safe, effective, and large method of contraception. We all know what is postpartum period, but extended postpartum period is first 12 months after birth. We can programmatically, it is convenient to further define this time period, because we can introduce PPIUCD just after delivery of placenta within 10 minutes, or during cesarean section intracesarean, or just after the delivery of placenta, uh, or within 48 hours of pregnancy, but not between 48 hours to 6 weeks, just because of infection or bleeding or more expulsion. So we can use the first 48 hours of delivery, and after that, after 6 weeks of delivery till 12 months of birth. So we can have two types of IUCD: copper bearing IUCD or progesterone releasing hormonal IUCD, which releases continuously daily a small amount of levonorgestrel. So what does they do? Both IUCD, they prevent uh, they prevent the meeting of sperm to ovum. How? Because uh, they damages the ability of a sperm to get to meet the they damages the ability of a sperm, and they block the ostia as a physical barrier, and they make a sterile environment by copper. And hormonal IUCD further, what does they do? They make thicker cervical mucus, so no sperm can enter inside after reading. Next, we all know that in government program, copper T380A is available, but copper 3675 is approved for private sector. And in India, unmet need of birth spacing, 65% of women have unmet need. Only 26% of women are using a method of family planning in first year of postpartum, and 8% of women desire to have another child within next 2 years, and 1% of women become infecund. And return of fertility depends upon whether you are exclusively breastfeeding the baby, or partially breastfeeding, or not breastfeeding, or having lactational menorrhea, or you have returned to a sexual activity early, because 40% of women return to sexual activity within 3 months of delivery, and it increases up to more than 90% till 1 year of postpartum period. So So following in a version 2, return of fertility depends on this. What mode of action? Already I have told that IUCD interferes with the ability of a sperm to survive and ascend the fallopian tube, where it stimulates a sterile foreign body reaction in endometrial cavity and make the endometrium unfavorable for uh, implantation of blastocyst. Copper T380A is highly effective, more than 99% effective, and pregnancy rate is very low. Failure rate is only 0.6 to 0.8 per 100 women in first year of use, and it is effective for 10 years of use. Advantage, we all know that it is very convenient, saves time, additional visit, no additional visit is required, safe because it is certain that patient is not pregnant at the time of insertion. Just she has delivered the baby just now, and high motivation because women and family uh, can be motivated simultaneously in a batch, in a group. Uh, I, all family members are mostly present there, and they can decide about reliable birth spacing method, and there is no risk of uterine perforation because of the thick wall of the uterus, and there is reduced chance of heavy bleeding and lactational amenorrhea. Another advantage is saves the time as performed on the same delivery table as post-placental within 10 minutes of placental delivery, or intracaesarean insertion just before the uterine closure, or just after the placental delivery. And we can counsel them in these times, and infection prevention should be very strict. Aseptic insertion should be done because of risk of HIV, hepatitis B, and hepatitis C. Infection prevention, we all know how to wash hands and how to maintain aseptic procedure. So we all know medical eligibility criteria, means where is the category A is the condition where is no restriction, means you can use contraceptive method safely, and two, where advantage outweigh the theoretical proven risks. Two, in three, generally we don't use category three. We don't use, and in category 4 we never use. And timing PPIUCD can be categorized as post-placental, intracesarean, early postpartum, that is insertion within 48 hours of delivery, and delayed postpartum means interval PPIUCD insertion, that is insertion at or after 6 weeks of delivery, but no insertion of PPIUCD between 48 hours to 6 weeks of delivery. So technique we all know. We actually organize workshop for PPICD insertion. Even I have made a video for local public in Hindi, and I have demonstrated that how intraseasonal we introduce the PPICD. So we have to in intraseasonal we have to keep the T. We have to keep the U-shaped PPIUCD in between two fingers and introduce while palpating the fundus, just not to perforate, but never try to locate your strings to the cervix, make it out. Never try to do it before uterine closure, because it may displace the PPICD. And instrumental insertion is by a long forceps without lock, where you have to keep this IUCD in between the both the blades of the forceps, and you have to insert inside the till the fundus is reached, and then IUCD is released. Here you have to keep in mind that forceps should not have any lock. Next, so these are the method how to introduce. We know all. So follow up is very important. We have to do follow up according to need based or on regular basis. So adverse effects are very few. Some infections, bleeding, or prolonged hospital stay. Sometimes you may need. Otherwise, generally you don't need them. There are very few adverse effects or no side effects. Expulsion rate is high, even 8 to 14% of percent are noted after PVP IUD insertion, and it affects the timing of insertion, type of IUD, route of insertion technique, and it is lower with cesarean. So management with pain, for pain you can give painkiller, and for displacement, if it is not contaminated, you can again displace it under aseptic method. But if it is contaminated, you have to insert the new PPICD if it is contaminated. So management of potential problem, cervical laceration, so repair may be needed, or uterine perforation, maybe you need to suturing. So PPICD is safe and convenient, time saving, large with minimal risk of perforation. Expulsion rate is high, but retention rate is 90%. It can be done following delivery of placenta during cesarean section or within 48 hours of childbirth, and type of insertion may be post-placental, where you have to insert within 10 minutes of placental delivery, intra-cesarean before uterine closure, early postpartum within 48 hours of delivery, and delayed postpartum means at or after 6 weeks of pregnancy. It should not be inserted within 48 hours to 6 weeks for a risk of infection, bleeding, uterine perforation, and mostly expulsion. Thank you for patient hearing.
About the overview of a contraception where we stand today. Today is again the special day for me, because being a year is been started with the presidency of Dr. Jaideep Tang sir. We started with the new team in Family Welfare Committee, and all of them are very enthusiastic to work upon, as well as they are very much keen in a social media also, because today whatever we thought we enjoy our things is to see and to correlate ourselves in the social media. So here is today I will be talking about overview of the contraception where we stand today, and thankful to all of you to listening to me. We know we have a diversity in our population, we have diversity in our religion, we have a diversity in what we wear and what we think. So the what we give a more contribution in the different fields, we give a contribution to going down to the Chandrayaan, that is the first achievement in the last century. But definitely this is not something good that India contributes to the world population in the number one country. So that we need to think about the what to be done, and what is exactly the contraception can do to our country's population. Today's agenda of my presentation will be epidemiology and statistics. All of us should know what are the exactly we are going to talk about and what are the statistics means to us. The available method with the last updates, we know the implants which is coming up and what it's actually mean to all of us. Where we stand today and the national family planning programs we must be advocating, and we all of us are talking about AI in different systems, AI in our laparoscopy, AI into our infertility. So we will be talking about AI and its learning in contraception. The epidemiology and the statistic in India, we know the fertility rate is decline. If you are talking about the urban and the rural population and the total fertility rate, by the national survey 5, we come to know that the fertility rate is decline. But saying so, it's we know that the total fertility rate is declining from the NHS 4 to NHS 5 survey, but the unmet rate remains the same, or it is not that much statistically increasing. The percentage of the need to spacing is also remains the same. So we need to work more on the family planning itself as a service provider, because we know there is a demand, but the unmet need is statistically significant, easily been there. It has not been reduced in years as the NHS data states here. We know that the types of contraception being used in married couples. I know there is a formally that is a modern contraceptive methods and the traditional ones. But if you see this particular chart, which has been published by NHS 5 survey, the non method is being used is the worst. What is worrisome to all of us? We know the female sterilization is still the leading acceptable things in India, but definitely we need to improve on our LARC methods, and that's why as a FOGSI also we come up with the FOGSI focus and the GCPR guidelines in the last year. The story of the success in our family planning program is advocacy and the need to know our population based strategies. We do understand that every population has a different need. If you're talking about the rural population and the urban population, their need of family planning is different. Their acceptability for that method is different. We do understand there is a difference in the cultural belief. We do understand the sustainability of the particular method for adoption. So if you see the condom and the pills, which remains the statistically significant in the steady things, but if you're talking about PPIUCDs, which is been increased as far as the rural and urban population is been considered. We do understand that there are the certain states in India which needs to do the advocacy in family planning services, because if you see the Uttar Pradesh, Bihar, these are the countries wherein we need to understand their family planning programs, and the national advocacy should be implemented more forcefully by the government as well as the social NGOs and the Federation of FOGSI also. Because if we need if you're thinking of the sex ratio and the acceptability, because Dr. Nirja also talked about the unwanted pregnancies, and this way usually leads to unintended pregnancies and illegal abortions later on, and that's one should be taken into account. We know there are the availability of the methods. These are the different availabilities of the birth control methods. We know the condoms, we know female condoms, male contraception, as well as the injections and the IUCDs. This usually have two different things. There's a short-acting reversible contraception and long-acting reversible contraception. We need to understand that there is something which is newly come up with the implants, and that has to be advocated in our society. WHO has a different type of approach. They have these particular things that have been differentiated into a short reversible acting contraception and long acting reversible contraception. When we're talking about the family planning as a whole basket of approach, we need to understand in which population, whether it is adolescent population, whether it is a reproductive population, what is their need, whether they need a contraception for their long spacing for that particular thing, or may they require a short-term benefits of this particular methods. The India itself has a contribution in the family planning. we do understand there is a advocacy which is required. We required that particular things to communicate. We required the communication skill to the patient. So we required the advocacy. We required going into the deeper roots of the community by showing them the pamphlets, with giving them actual need of information and what has been there. As a Indian policy, we adopt different strategies. We do know we come up with our own research of a DMPA subcutaneous with the aqueous solution. The 55% of the country's populations living in 24 countries already achieve the replacement level, and that's why we are little bit happy about it. But still, we have to work on the Uttar Pradesh, Bihar, and Jharkhand for that matter to achieve our goal as far as the family planning is considered. The female contraception usually come with the barrier methods. All of us knows their effects and the basically these are the female condoms, diaphragms, cervical caps, and the contraceptive sponges. What they usually do, they do have dual role. They have the contraception benefits as well as the STIs which can be prevented. The oral hormone contraceptive pills, we do understand there is a progesterone only pills and the combined hormonal pills. Combined hormonal pills come with the progesterone and the estrogen. When we're talking about the progesterone has a first generation, second and third, and the fourth generations, which is really having a less side effects per se. The progesterone only pills is been advocated and it started from 1960s, and which come with the non-ethisterone and norgestrel. Since 2002, desogestrel containing pills like a Cerazets look into the market and has its role. The other hormonal methods, we have vaginal rings, we have transdermal delivery systems, we have a contraception like injectables like a DMPA. We have DMPA subcutaneously, which is coming up now. We have IUCDs like LNG IUS or maybe a simple copper T and contraceptive implants. The not to forget about, because it's a equal responsibility for the family planning programs to be having the advocacy. It's related a equal responsibility to distribute in these particular programs or maybe services into the population of the female as well as the female. The male, when we're talking about the male contraception, we also know there is a barrier methods, there is a vasectomy and the Risuk, which is our own development by India, which is reversible long-active contraception as far as the male contraception is considered. The non-hormonal, this is what I talk about, is a centrochrome, which is our own product by the government of India. It is available by the name of Chaya. It is the active ingredient is oralmaxin. The non-hormonal oral contraceptive is developed by our own in Lucknow. Is suitable for the woman with the medical comorbidity as well as in postpartum period, where a COCs is contraindicated, and that's why a centroman is our make. So they see when you talk about made in India, this is the product when you should be talking about. Coming down to the long-acting reversible contraceptions, definitely we have a spermicide subdermal implants. We have come up with the LNG IUS. We come up with the copper T. What is now we advocated in certain. We started the project with the government of India in Bihar and Jharkhand. That is the implants. The implants we are in the first phase of the insertion, and later on it will come with the removal, because the implants per se has a duration, and then the people will should be trained about it, where to put the implant, how to remove the implant. And with the organon team, we are as a family welfare committee chair, we are making the workshop in different areas of a FOGSI, wherein we advocate the insertion techniques. We show them how to do the implants insertion. It is a onset is within the 7 days. The adverse effect, every has a contraceptive device when it is hormonal needs to we need to understand there is a adverse effects. So without adverse effects, we need to counsel the patient that there may be some of the times there is irregular spotting, or maybe there is a insertion site, there is a bruise, or maybe you require a little kind of a tight dressing for that matter. Menstrual clamps will be there, or the skin changes in the upper arms will be there. So when certain things has to be talked to the patient prior to taking their advice or their need into account. So these are the contraceptive implants. It is a biodegradable single implants with what we call as implanon. which come up with the high contraceptive efficacy. The Pearl index is really a negligible 0.05%. Multiple training camps, we also been now doing it on a dummy arm, and actual insertion is been done in Bihar state and Jharkhand by the government of India also. Shall it requires a little bit what do you call as training, but once our practitioner are going to get trained, it is very easier for a long acting reversible contraception as far as it is efficacy is considered. The Risuk, which is a male reversible long-acting contraception, which is developed by Professor S.K. Gua from IIT New Delhi. Now he is working in Kharagpur. The trials is already undergone by ICMR. It is reversible. It is a sperm under the guidance, and what it actually has a SMA which is 60 milligram, and having said that it has to be dissolved in DMSO and it is a reversible method of a male contraception with a high efficacy of the contraception. We know the vasectomy is being advocated, but somehow the male partners are not keen to go with it because it's a permanent method of contraception. Now, this is something which is really come up as a reversible contraception in a male itself. So we are looking forward for this also the training in futures, and we can educate this as a one of the LARC method. The emergency contraception definitely is a need. There is a WHO product WHO program like they advocate. It's a one station wherein you need to give a emergency contraception as well as the contraception as a one of the method. Definitely, this is the tool only in the emergency conditions. It cannot be advocated as a routine practice. We do understand there are the single dose, that is a split dose, ulipristal acetate, and the insertion of the copper D or maybe a COCs can be given. All of us are known that, so I will not take into the details of it, but definitely wanted to emphasize one thing, that this is a resort, not as a routine practice as far as the family planning services is considered. We come up with the programs which has been launched now, the initiation of the population stabilization. Here we know this particular हम दो हमारे दो. Now it comes with the हम दो हमारा एक, जिम्मेदारी निभाओ and plan बनाओ. You need to have a planning for your futures. It's not like a हम दो हमारे दो and then you realize into unwanted pregnancies and then going into emergency contraception or maybe a MTP. So this is not the things. Now it is been changed at the 360-degree holistic approach. One should know what is our zimmedari, and that's we need to have a planning for every surgery. As what we plan, our patient should also plan for the pregnancies. We need to have a preconception counseling. We need to give them a contraception as a one of the basket to offer them to need to their spacing of between the two children, and that has a importance as far as the 360-degree holistic approach is been considered by our government of India. The key highlights of this particular family planning program by the National Family Planning guidelines is the policy level. The policy is a target-free approach. Initially, when the policy has been started, is like a target approach, but nowadays we talk about holistic approach in which it is a target-free approach. It is a voluntary adoption of the family planning methods. It has to be voluntary. And that voluntary adoption requires a counseling, requires your Facebook, your requires Instagram, go to the public, talk to them, get their feedbacks, and then make the policy. These are the policy levels wherein the voluntary adoption is one of the instrumental pillar of that particular policy level decisions based on the felt need of the community and the children by the choice and not by the chance. All of us in the previous generation thought the bacha ho gaya to ho gaya. It's not like that. It has to have a children by choice. It is the choice of the lady that matters rather than it is just a chance which is happening, and then we are thinking of a next pregnancy which has to be planned and something like that. The service level, it is more emphasis on the spacing methods, assuring the quality of the services. If you go to the PSC or maybe a tertiary health services, wherein there is a quality of the services is been assured and the expanding contraceptive choices. We come up with the short reversible contraception, then long reversible contraception. If someone has to say implant, so that is another advances of it. We are come up with our own made in India product like a Chaya. So everything as a service level, this has to be assuring the quality of the services as well as the expanding of the contraceptive choices. So, what is the key initiative and the schemes is promoting the quality of the sterilizing services, promoting the quality of the IUCD services, generating the demand and awareness. What we do it in our younger population by the Facebook or maybe Instagram channels, addressing the global commitments by the family planning. 2030 is the goal. When I've been to the Nepal, wherein in a 2030 summit, we have our global commitment as far as the family planning services is considered. It is a more of the private sector as well as the public sector should be in association in making the policies, making their demand as well as the supply, and also there we had a discussion regarding the implementation of this particular services, augmenting the demand through the schemes of the family planning, the home delivery of the contraception, ensuring the spacing of the births, the pregnancy test kits, like Asha kits as a emergency management of the pregnancy should be advocated. The Mission Parivar Vikas is one of the things that the government of India come up with. What the objective of it is to accelerate the access to the high level quality of the family planning choices based on information, reliables of the services, supplies of it, and the right framework. What it requires is a right framework of the program, supply and the demands, and the commodity which has been available for that particular method. So timing and the phrasing is implemented in the missions of 146 district at one go and not in a phases. So what it means that if the commodity is there is a demand, but the commodity levels are not that much available, what will require is an unmet need, and this has to be taken into consideration when we talking about implementation of the these schemes, and that's where we talked about the holistic approach. The new communication campaigns, definitely we have a celebrity WhatsApp videos, we do have a toll free helpline numbers, 52 weeks long radio chat shows, and a family planning web page, print and posters and television ads. It's my privilege to talk about this thing because my committee members were be selected 25 by my own, and the FOGSI has given 25. So it is a family of 50 members, and when we talking about 50 as a strength for a particular committee, we are making this particular communication campaigning into the schools. I should name few members here. In the past year Dr. Avir and Dr. Priya and Dr. From Delhi, she has made a tremendous efforts going to the schools, going to the teaching coaches and the classes where they advocate this particular campaigning through their own videos, through their own giving the pamphlets, and we are happy to collaborate with the different universal donors like USAID or USFPA, wherein we take their grants, we make the pamphlets, we distribute them to make it more advocacy uh, into the public as such. The unified software by family planning logistics is a supply chain management, which I talk about the commodity. Commodity is the where you have a different choices of the family planning is been available. But if your public sector or maybe a private sector having some demand of some of the commodity, wherein it is not been supplied or there is a scarcity of the commodity, that has to be taken into account. And how it has been done, because there is instant access to the stock from the national level to the ASHA level, auto forecasting of the contraceptive, where is then which district the contraception for, suppose for the cooperative is requirement is higher, in which states this is at a lower side. Immediately in a one click, that at the national level will come to know what are the uptake of the particular contraceptive options are there, and it is auto generated reports, and so that once our reports are auto generated every 6 monthly, our mission for making the policies are very much easier. Definitely from our own FOGSI as an organization, we make a little bit effort of making a AI tool which has been devised by Dr. Evir in association with all of us. We are approached to the FIGO, wherein there is a AI which has been incorporated into that app. If you are just have a BMI and underlying conditions, or maybe you just Google your every ideal things will come up, and ideal contraceptive for that particular patients will be there. And now we are going to add up the FOGSI data to this particular app, so that if the patient needs to go and access to the FOGSI members like Ola and Uber, she will automatically directed to that particular member, so that that member also will get to know this particular patient has a need for providing the family planning services. And this is an integrated approach as far as the AI is considered. This is a something which are going to be formed maybe in a 2 or 3 months. We are able to give you a product wherein the patient herself will go to the FOGSI members in order to have gather more informations for this family welfare services related. Today we had launched this Insta page along with the Facebook in order to have for the public itself, because the public wherein we need to go, we need to show our videos, we need to give the awareness of the family planning services what we have. The sex education for the adolescent is one of the things, because this talk is not been complicated completed without talking about the sex education. Because when you're talking about overview of the contraception, it starts from the adolescent, and then in the reproductive age group, and then further. So whenever we're talking in adolescent, we need to know their needs. We need to, you cannot be just that this is wrong or this is right. You cannot be optimistic by giving them your thinking. You need to listen to the adolescent, give them education, what is the best for them, and need to understand that there is a possibility of sexual transmitted diseases if the proper counseling is not being done. It's not only for the family planning for them, it's for the prevention of the sexually transmitted diseases also. These are the percentage wherein we conducted the camps, where in the school colleges the uptake ratio, and where they are talking about the sex education and the family family planning, what they thought in their mind as far as these issues are considered. So to conclude my talk, the national standpoint, there is clearly a to desire and need to introduce more contraception option for the general public. More researches are needed to assess the choice and acceptability of the public, and unplanned pregnancies still continue to occur. More research is needed in the field of the male contraception. Government and non-profit organizations are needed to devote the necessary resources for long-term efficacy of the family planning in our country, because this is the need where we need to talk about. We are unite together. It's a, whether it is a FOGSI, whether it is a US FDA, whether it is a WHO, all of us are working for the woman's health, and that requires a together effect and an amalgamation of all of us. So साथ मिलकर अपने मिलकर सपने सजाओ, 20 साल के बाद खुशखबरी सुनाओ. So these are the things that needs to be talk to our clients, talk to our patients, and give them information what is needed. Thank you for. Is it?
Yeah, it is visible now.
Yes, sir.
So today my talk is a population stabilization and birth control challenges and the methods. All of us knows that we are the populous country in the world, and we share the 1/5 of the population, world's population. But saying so, we do understand we have a certain states which has the TFR of 2.1. The certain states are not doing that much very well, but definitely being a chair of this particular committee, we are committed to do our work for the betterment. It's not moving. Oh. Okay. So where do we stand? As per the latest data, the India is currently the home of the largest population in the world, and the India is took over the China in 2022. You can see this particularly, and now the Dr. Jam, madam already talked about that. We are already having said that the birth rate is much more increasing. The population of India plus China is more than 1/3 of the world's population. So population explosion and world stabilization, the explosion, the exponential increase in the size of the human population within the small period of time we call as a population explosion. So anything that's related to the explosion, when you call as an explosion, that in a short period of time, if we are surplusing the amount that we are expected to have, is called as an explosion, and which is happening in the population also. The population stabilization refers to the statistic population size over the definite period. So we need to have our family planning services, or maybe our strategies, in order to have the population stabilization done. The natality rate is increase the number of individuals in the population under the given environmental condition is called as natality, and the increase in the number of individuals per unit time is called as natality rate. The why I'm talking all this in a detail, because we need to understand what is the terminology and what we can actually do about it. The mortality and mortality rate is the loss of individual due to the death in a population under a given environmental condition is termed a mortality, and the mortality rate is indicating the number of individuals dying per period. So population explosion and the population stabilization, if we talk about the explosion, I told you in a stipulated time, if our certain numbers are increasing, and that is exponential increase, we call as explosion. And what we need to understand, we need some strategies for stabilization of the same. As a result, there is a steep fall in the mortality and increase in the longevity. Why it happens? Because we know that our longevity is increasing, and we know there is a steep fall in a mortality rate. The based on the natality and mortality rate, the population explosion and population stabilization can be summed up into a population explosion is equal to, if the natality rate is more than the mortality rate, we definitely going towards the population explosion. And if the natality rate is equal to the mortality rate, that is called as a stabilization. So when we're talking about the stabilization, we need to understand the natality rate and the mortality rate, if it is equal, or if the natality rate is going down and the mortality rate remains the same, then definitely we are going to achieve the population stabilization. What is the factors that is influencing the population growth is, first is the factors that depend upon the population growth is definitely government policies, the social norms, economical growth, the educational cost, as well as the migrants. But the migration usually happens because if in certain areas of the world, if there is not a good economical growth, or maybe the education is not that much great, there is a definitely a migration will happen, and this will leads into the factors which are affecting the population growth. Particularly the female the participation of the female labor market and the standards of healthcare, it also affect the stability of the society, the cultural attitudes to the family size. That is one of the factors that influence the size of the family as well as the population itself. The availability of the contraception as well as the family welfare services, that is also the important thing in order to have the population growth in our hand. Recently, NFHS data 5 confirms that India is a well on the course of towards the population stabilization, and it is expected decline further to 8.4% in a 2021 to 2023 2031 decade. If you can see here from our chart, the birth rate and the population growth rate is going to go down, and that's what we need to understand, and we need to have uh, in our thinking. The India's total fertility rate have been steadily falling across the India in the rural areas and in urban areas. The quite apart from the India reaching the replacement level, what I was talking about is 2.1. The quite achievement that the 5 out of 28 states and 8 union territories also achieved this TFR. That is, the 31 states has already achieved. Only the Bihar, Meghalaya, Manipur, Uttar Pradesh, and Mizoram has not achieved that fertility rate and the replacement level. What needs to be done is measures to control the population explosion in India. The measures from the family planning measures, economical measures, and the social measures. These are the three pillars of any of the strategies, and that needs to be inculcated upon. The will come down to the stabilization in the population is easier than said done, because we do understand there is a overall development in the population control can be achieved by overall development of the woman. The woman herself needs to have a have access to these particular services, as well as she herself has a choices to choose on upon. These are the what are the services available, and definitely she should be empowered socially, economically, and educationally to have this access, have to choose what are the modality of a services she can afford, and she can and go along the promoting the family planning and the contraception. That is the one of the strategies to talk about, increasing the access to the reproductive health choices and the services, raising awareness about the benefits to the smaller family size. Now we do have PM Yojana, that is a Parivar Vikas Yojana, which is implemented in 2016 by PMO, and which also says that we need to have a holistic approach towards these services. The need of contraception in India, the largest population in India, accounting for 17.76 of the total world population. We know that India surpasses the China is 2022. The fertility rate in 2023 is 2.1, and which has been achieved in many of the states. Even the small increase in the population has a major impact on the global environment, including the excessive consumption of the resources, was what was the previous guest was talking about. So there is a need of a strong population policy to control the population and the growth by providing the access to the effective contraception methods to all eligible couples without any thinking of any of the issues or accessibility. It should be a universal policy for the country. The need of contraception is again the 40% of the pregnancies in the worldwide is unplanned, and that's what today in the morning the JP Nadda sir was talking about, that we had reduced the 6 crore unintended pregnancies this year. The 20 lakhs abortion has been decreased in the abortion rate, and that is because our uptake of the modern contraception services is increased to the 56.5%, and that is a good uptake by any of the country in the world. And that's why we are working towards our goal, but it is not the half the journey has been done, and still there are much more things to be done in this field. The birth control methods and the goal to the population stabilization, definitely it's a we know there are the different methods available. There is a short acting reversible contraception and long acting, but nowadays what I feel, when you're talking about a population stabilization and the contraception methods, it should be the first thing is a acceptability of the population. Secondly, availability and the resources has to be talked about, and third is a LARC method is a long way to go for it, because it's a long acting, being it's a reversible, it's a more acceptable. But the only one thing is that in a private sector we need to implement them. We need to have a council to our population that these are the particular methods which are available in order to have a healthy family and a achievable goal in a larger aspect. So the type of the birth control, we know that there is a continuous abstinence or maybe a natural family planning rhythm method, barrier methods, hormonal methods, in implants, and permanent birth control methods, and the emergency contraception. The WHO also come up with a good kit that is called as a self-care kit, and that also has the emergency contraception in it. But saying so, we need to have from the government of India, we are discussing the implants, and the implants are already this is been done in Bihar and the Jharkhand, and with the private sector, with the Organon, we are come up with the training of the trainers. FOGSI itself has done a 32 programs of the TOTs. Again, we had done in Armed Force Medical College in Pune itself. So it's a universal efforts are required in order to promote this long acting reversible contraception methods in order to have a population stabilization. The female contraceptions, definitely there was a role of it, but it is a short reversible, and it requires a little bit daily talking to our service provider has to be talked to the major population, and they have different methods like a female condom, maybe a diaphragm or cervical caps. But saying so, these are the methods. When I talked about like population stabilization, what we need to understand, there are the methods which are been there for years together. These are not something new, but when we are talking about the stabilization, we need to talk to our clients that it is a long acting. Saying so, that visits to the clinic is less. The less is a cumbersome for the patient, because if you are talking about the daily use, or maybe a patient requires remind us for the same, it means that the acceptability will go down eventually. So it will be always acceptable that you should have a longer acting something that holds true for the stabilization purpose. So we do understand there is a combined hormonal contraception and progesterone only pills. I'll not go into the details. Other hormonal methods is a vaginal rings, injectable contraception. Nowadays, Antara project is been launched by the government of India, and the DMPA subcutaneously is coming up, and it is going to get distributed from the all the public as well as the private sector, saying that whenever there is a self administration like a subcutaneous administration is been advocated, the acceptability in adolescent population is much more higher, which I had seen the changes in the Kenya where I happened to go, and here in their country the acceptability to this injectable contraception or maybe a implants is higher, because the young population usually don't want to have something to carry along or something to use when the need arises. So these are the certain things which we need to cater and need to have a more focus for our delivery system. Then we'll come down to the male contraception. Definitely there is a barrier methods, vasectomy and risuk. Risuk is our own development from our India, and it is a reversible contraception for the males, and it is a really a good thing, but more studies are required in this particular as a LARC method for the male contraception. The non-hormonal contraception, when you're talking about made in India, always we are proud of it being a chaya, that is a synchroman, which is a active ingredient of ormelavaxifen. It is a non-hormonal oral contraceptive, and it is been now well accepted by many of the government sector as well as the private sectors also. And we are happy that this particular project has been launched, and it's going very well as far as the acceptability is considered. The long-acting reversible contraception, which I already talked about the implants, gone are the days when we are using the two implants or two rod insertions. Nowadays, we are come up with the single rod, that is the implanon, and which is easier to be instituted into the subcutaneous way. Being a gynecologist and being the member of the FOGSI, if we are doing so many procedures in OBGYN, it is a really a very easy procedure. It doesn't require much more of your the time of a practitioners, as well as the acceptability of the client is very much high. I myself has inserted more than 20 inserts, and it is a little bit training is required because it's a invasive, and once you are trained into the implant insertion and removal, it is the easier way, and basically it is acceptability for the adolescent population is much more higher, and which I have seen the majority of the girls are going and asking for the same. So it is always when you're talking about the stabilization of a population stabilization, it is always better to talk something which is a long lasting, because these are the population, as I told to you, more than 60% of our population is now coming into the adolescent age group, and much more younger generations required a longer acting methods, and that is the one of the need when you're talking as a consultant to the our patients. The risuk is a new LARC method for the male. It is developed by our IIT Kharagpur. It is a successful multicentric level 2, level 3 trial is already been done. It is a reversible inhibition of the sperm under the guidance. There is a SMO and DMSO 1:2 ratio. It has to be dissolved and has to be injected into the spermatic cord. It will cause the blockage of the spermatic cord, and then but it is a reversible. So if one patient requires to get the fertility back, we can have again, there is a dissolvent which has been there. You can inject the dissolvent into the same point, and the track is going to get functional again. The emergency contraception is a need, but it should not be advocated as a routine things of a contraception. But definitely there is a need. There is a certain the population age group, or there may be a subset of the community which require this kind of a contraception methods, and you cannot just say no to it, because it has its impact on the population stabilization. And we know it comes as a commercial brands, as well as you can give a ulipristol or maybe a copper T insertion or maybe a oral contraception use regime. But saying so, whenever you are talking to the adolescent age group for this particular as a contraception option, you can always talk to them. This is a one of the option and not the only the strategy to look forward. So unmet needs it's of the contraception is a big issue, because definitely we are achieving that target, but the target in certain states are really difficult to achieve. Why? Because of the diversity in our population, diversity in our community, diversity on our family sizes, as well as the religion is also considered. That is one of the thing that has to be a issue, and that issue been be solved, because nowadays we are capturing the data according to the district level. If we get the data from the district level, it is very much essential and for apt for the government of India to implement the strategies at the district level, so that the population stabilization can be done. So the comparison, if you wanted to really compare between the our health survey of a 4 and 5, you can see there is a not much of a difference as far as the female sterilization is been considered. But if you can see, the total unmet need is going to go down, and the unmet need for the spacing is really gone very much down in that particular survey. The overall unmet need for the contraception in India is estimated to the 9.4%, and the unmet need for the contraception refers to the gap between the woman's reproductive intentions and their contraceptive behaviors. And what is that unmet need? Is we need to, as a worker in a family planning services, we need to understand these are the things where we need to work upon, and we need to this particular gap we need to reduce it down in order to achieve the goal. The goal is a one thing that's usually what we talked about. The India approaches to addressing the unmet need for the contraception align with the global efforts. But whenever the WHO or UNSFDA comes along with the FOGSI, we have a aim of 2030. That is our global vision, where the India being international health declaration as today is the great day for all of us. That again, the government of India with the what we made in the Nepal to have our achievable goal of a 2030. The statement is has been released today itself, and I will be happy to deliver it to all of our members, because these are the statement given to us to achieve the goal in 2020-30, and that can be definitely we are going to go for it. While India has made a notable progress, and the gap remains when the compared to the global standards, the contraceptive prevalence rate, the India is stands at a 54%, which is lower than the some of the developing countries. We do understand there is access and equity. What is need to be done, that we know, definitely know there is a difference in the socio-economical groups. There is a difference in the urban areas and the rural areas. As far as this um, contraceptive uptake is considered, we need to understand there is a difference between the uptake ratio, and that is usually related to the socio-economical barriers, lack of awareness, lack of education, access to the service. That is one of the things that, if you're talking about the 5 states, majority of them are in the northeast. Why it is not been achieved that much faster? Because the access to the service is also a problem. We need to talk about the quality of the care and the economic constraint when you are going to talk about the contributing factor for the unmet need. And that's why, if you are thinking of what is the ideal things, and which is going on a steady and increment shall uptake, so DMPA and subcutaneously DMPA on the implants has a much more uptake ratio as compared to the rest of the contraception, because this stands still till today. If you are compare the NHS 4 and NHS 5 rates, you can see the India, the wanted fertility rate is somewhere 1.8. Now we have a 2.2 in majority of the states. If you're thinking of the rural and urban population, rural population is what we are going to achieve it much more faster as compared to the urban, though we thought it in different ways. But if you are thought about the different regions of our country, the Uttar Pradesh, the total fertility rate is much more higher as compared to the Rajasthan. If you compare the religion wise, the Hindus are much more total fertility rate we are achieving much more faster as compared to the Muslims. But saying so, The close to 98% of the women know about the contraception methods, yet 48% of the women they use any modern methods of contraception, and the uptake of the modern contraception now we achieved the 56%, and which is as compared to the last year, which is a remarkable journey as far as the family planning services are considered. The currently married woman, if you are comparing the NHS 4 and NFHS 5 survey, the modern methods uptake, whatever as I was talking about, is 56.5, which was really a remarkable journey as far as the this particular family planning services are considered. Marginal increase in use of modern contraception methods over 15 years, and that's what we really should celebrate our success as a success of a family planning survey. We'll come down to the contraception. Without saying that the conceptual framework of the factors of the influence the contraceptive uses is a what is the usually influential things nowadays is not a Insta and Facebook, is your media presence. You are talking about to the clients, talking to the different generations, because adolescent populations require this particular counseling. They require much more of your time. They require your comfort zone, and that has to be talked to them as far as the contraceptive options are considered. We need to look at this in a framework of the community and the family characteristics, the social burdens, husband knowledge about the contraception, and that's why the Uttar Pradesh come up with the yojana, where they call up a husband, they call up a brother when this particular counseling is going on. Why? Because the male participation into this is also important for our success towards the population stabilization. The government initiatives and the policies are also there. We'll just touch upon those, because without saying and without the support of the government, we cannot achieve this goal. The Mission Parivar Vikas is launched, which I talked about in 2016, and we are working with the government of India. We are just having alignation in the same line. We are not changing from one goal to the another goal. We have the Mission Vikas Parivar from 2016, and we are continuously working on the same. And the credit of today's what you call as success of family planning services in India to consider we are modern uptake of this particular contraception options is 56%. The majority of the credit goes to the ASHA, and that is because of their work in promoting the contraceptive use and providing it to the doorsteps. And the government also has different policies, as a Pradhan Mantri Surakshit Mitratva Abhiyan, and Jana Suraksha National Population Stabilization Fund, and which is also important things to contribute upon. The India contribution to the family welfare is a Chaya, which I already talked about. Antara, again the Chaya and Antara, every 21st of every month there is called as Antara project in Uttar Pradesh. They do this Antara distribution every 21st of the month, and this is well uptaken by the PSC centers and the tertiary healthcare also. The family planning programs now achieve the goal, and now we talked about the holistic approach. Instead of talking about strategies, we talked about a 360-degree holistic family planning campaign. The new logo will tell about Zimmedari Nibao and Plan Banao. What is a Plan Banao? We need to talk to them that this is a safe, that woman has a reproductive choices. Similarly, she has her own decision when to have the kid, when to have the family completion, and that's where our mission is, and where if we go in that line, we can achieve our goals. The key highlights of the family planning programs in order to stabilization population is a target-free approach, voluntary adoption of the family planning methods, and that based upon the felt need of the community, the children by choice and not by chance. The service level is more emphasized on assurity of the quality of the services and the expansion of the contraceptive choices. And in order to have the key factors in this, what I believe is a expansion of the basket of the family planning services, augmentation of the ASHA scheme for the family planning, promotion of the quality services, promoting of the more IUCDs and LARC methods, generating the of 2030, what we should be talking about. The augmentation of the augmenting the demand through the ASHA scheme of the family planning, depending upon the home delivery of the contraceptive, ensuring the spacing of the births, pregnancy testing kits. Now we come up with the safe kit or the self-care kit, which comes with the pregnancy test, along with the pregnancy testing kits, or maybe emergency contraception as well as along with that. The Mission Parivar Vikas has a pillar of a strength, delivering the assured services, devoting the new promotional scheme, ensuring the commodities securities, building the capacities, creating the enable government for close monitoring of these particular things in order to come up with the bottlenecks which are there. The new communication campaigns we have from the FOGSI also last year we done a launch of an app which gives a appropriate method of a choice to implement upon. So this was the app what we launched in 2023. It depends upon, and also it has a contraceptive chatbot, so any of us can go just and the ideal contraception method will pop up, and which will tell us which is ideal for that particular sector of the patient. The sexual education for the adolescent and youth, this is something that we need to talk about, and for this many of my committee members are going and delivering their talks to the adolescent, and that has an impact for the population stabilizations too. To conclude, from the national standpoint, there is clearly a desire and need to introduce more contraception options for the general public. More research are needed to assess the choice and acceptability for the public, as well as unplanned pregnancies still continue to occur, and this is really a issue to talk about. More research is needed in the field of the male contraception. The government and non-profit organizations are needed to devote the necessary resources for long-term efficacy for the family planning in our country. And
so I'll be taking very small time for, just allow me to make it full screen. I'm not done that.
Yes, ma'am. Click on that.
Is it visible full screen now?
Yes, perfect.
Yeah. So, respected chairpersons, I would just like to give a very small brief about a very important topic, that is roadmap to population stabilization, how we can reach the unreached. After the elaborate presentation by our committee chair, Dr. Ashish Kale sir, we have learned a lot about this population stabilization today. And there was a famous English proverb in the past, what we all are hearing, the more the merrier. But here the more is not so merrier. In fact, that is a problem. The problem is of population control, of controlling the explosion, which is taking place on daily basis. So how this high population, human population, it can impact the natural resources, it can hamper the social infrastructure, and therefore a stabilized population can only ensure a citizen gets an equal access to the right amount of resources and live a life of dignity. And once the resources have been breached out, there'll be definitely a problem. So adopting a right-based approach, the need is to provide voluntary and safe access to the family planning services. This access will empower the women. The women can definitely then choose or reduce the pregnancy-related health risk, leading to reduction in the infant mortality rate, and hence, in totality, a comprehensive policy for population stabilization can get in, and this will help us achieve in moving towards a healthier population. So, as I said earlier, the population problem, I want to repeat, it is a problem now. As many refer to it, it is not about numbers. It is about people. And more importantly, it is about the lack of knowledge. It is lack of the services. We are not able to give it to the Indian women. So there is still a large unfinished agenda which is linked to the population stabilization. And this has to do with addressing the reproductive rights of the unreached. Unreached, specifically those women who continue to have more children than they want to, or more broadly, there is a large majority of women which are extending beyond their poor socioeconomic strata, And there are such women who don't even have rights over their own bodies to exercise control over the marriage and fertility decisions. So, who are these unreached? The ones with the social cultural barriers, the one who have lack of awareness and education, the one who have lack of access to the services, those who are not able to get quality care, and the ones with economic constraints. And why are these unreached? Many are unreached because of the gender and age, as in the case of women and the children. So there are a lot of challenges which are associated with the population stabilization, which have been talked about earlier. Literacy and education that holds a very important place because illiteracy leads to early marriages, which not only increases the likelihood of more children, but also put a woman's reproductive and body health at risk. Beyond this, because of the lack of education, the people are not able to utilize the important resources which are available in family planning basket. They're not able to utilize the contraceptive methods because they're not aware, they're not literate enough to cater to their own personal needs. So there was a study by the NFHS 5 survey which said that education level of mothers they matter. Mothers who were 10 or more, or who did 10 or more years of schooling, they reported a total fertility rate of less than 2. Similarly, coming to the socioeconomic factors, in our Indian scenario, the preference of a male child can also be considered as a biggest challenge for the population stabilization today. There's a misconception that this male child will only run the family from an economic and hereditary perspective. While running behind this misconception, people then never realize that it is not only increasing the birth rate, but it is adversely affecting the reproductive health of women. So this is again a National Family Health Survey from 5, and it says that better economic and social status is associated with lower fertility rates. Inadequate use of contraceptives, like Jayam Khanna madam has already said that southern states are doing well. Definitely they are doing well because the contraceptive prevalence rate is less than 10 in most of the northern states. Females in northern states, they still give birth to 4 or more, and they don't really rely on the modern methods of contraception, and they're still using the traditional old methods which are not so successful in achieving the goal of population stabilization. And this is again the National Family Health Survey 5, which says that there's only a marginal increase in the use of modern contraceptive methods over the last 15 years, as we can see in the data. In the year 2005-6, it was 48.5, and in 21, it is still 56.5. So there's not much a gross increase. So what are the suggestive measures for the planned population growth we can do? Delay the marriages, improve the medical facilities. Legislative actions have to really take a strict intervention in this thing, providing incentives to one who are utilizing the contraception. We can empower women by providing good job opportunities, by educating them, eradicate poverty, spreading awareness about contraception and the various methods available for them to take their own decisions, making contraceptive easy and cheap so they're readily available. Improving the overall development and education is the key to these things. And to make aware how to adopt the controlling measures, especially people of rural areas. Because when it comes to the contraception counseling and selection, what is there seen? We have to really establish a good rapport with the patient, identify those appropriate to receive the contraceptive counseling, because whenever a patient comes to our OPD, that is the right time we can offer the contraceptive counseling as well, be it adolescent girl, be it a young youth, or be it in perimenopausal years also, they are at risk. So we need to assess the medical history, highlight the contraindications of any of the method, initiate the contraceptive counseling process, elicit informed preferences for method characteristics, facilitate preference concordant decision making, and counsel about the method initiation and its use. So this is mandatory. The counseling is the backbone of any method or procedure. So these are the various strategies, like Sir has also talked about, raising awareness, strategies to expand the knowledge and awareness of family planning services. We are doing partnership in schools and various community organizations like social clubs to deliver sexual and reproductive health education. Then there are strategies to address the stigma and concerns about the privacy and confidentiality. We can set up clinic spaces to promote clients' physical sense of privacy so that even the adolescent won't have a problem coming to our OPD, and we should give a non-judgmental and unbiased consultation to such adolescents coming to a clinic. We should also address the fear and misconceptions about any of the family planning methods whenever a patient enters our clinic. Strategies should be there to prevent and mitigate the pressures around the contraceptive method choice. That is, we need to really focus upon the understanding the client needs and wants. Do they really want to change or remove the contraceptive method? If it is yes, then we should follow them. Be aware of the third party who could unduly influence client decisions. So we have to really counsel well. We have to take them into our confidence. We have to counsel about the pros and cons of any of the methods they are using. And strategies in response to racism, discrimination, and bias have also been taken into account. So there are various recommendations for the proper population controls, and most important ones are the increasing the basket of contraceptive choices with greater focus on the spacing methods, help women making their informed choices about delaying pregnancies and spacing between children, addressing to the social determinants of health such as age at marriage, sex selective practices, strengthening the quality of care, including counseling services, managing side effects, and family planning support, increasing the budgetary allocations for family planning, as Sir has talked about, to align with the unmet needs of the India's young population, addressing to the existing socio-cultural barriers toward contraception by investing extensively in the innovative behavior change communication strategies, and treating population stabilization and family planning as a national priority, fostering interdepartmental convergence and ensuring multi-sectoral participation and integration. So, to make a way forward, we need to promote voluntary and informed choice, holistic socioeconomic development, which includes good nutrition, education, and local governance to improve women empowerment, keeping girls in school, promoting more and more of education, because the girls who stay in school for long, they usually have the first baby at an older age and fewer children as well. Women's empowerment is what is needed now, and social and behavior change communication with focus on 360-degree communication strategies to shift social norms and enable communities to adopt to the desired behaviors. So what are these approaches to reach the unracial? Like, so we have talked about the family planning, family welfare committee has already taken the initiative of launching our first digital app, and that too in collaboration with FIGO, we are working on it. So these digital interventions, they are the services which can leverage the accessibility and reach to even the adolescents and promote their sexual, reproductive, mental health and well-being and online safety as well, because many a times they're hesitant, they're not able to come to OPD. Many are distant living in rural places, but they still have, in the mobile era, in the present era, where everybody is having a digital mobile. So digital interventions are the best to reach these unreached. Then there's strategic engagement, means engaging with the key stakeholders, the governmental organizations, the non-governmental organization, and the median domain of family planning, sexual reproductive health, and population-related issues should be discussed with them. The whole goal is to shift the family planning and population discourse to a gender-sensitive and right-based approach. We can also think of community action and accountability to strengthen the functioning of the health system. In tandem with the National Health Mission strategy of community action for health, we can enable the communities to discuss the availability and quality of healthcare services in the public health facilities and provide appropriate feedback to these healthcare officials. Aim is to promote the agency of youth, particularly led by girls and women within the community itself. And these participatory initiatives will bring out greater efficiency and accountability into public systems and delivery services. Social and behavioral change communication. This is much talked about SBCC. It is a key approach which has been used by a very important NGO, that is the Population Foundation of India, to effectuate the positive health and well-being outcome. The emphasis on this approach is driven by the understanding that the individual decisions are informed and influenced by the prevailing societal norms. Over the past few years, we have adopted and applied a 360-degree approach to SBCC using entertainment, education, and this innovative digital media as critical means to inform, influence knowledge, attitudes, and behavior. And we also, as members of FOGSI Family Welfare Committee, we have raised our quarterly bulletins raising awareness about contraception in the name of Ek Pehel, which was recently launched in the FOGSI Managing Committee meeting at Kolkata. So these are the behavioral changes. We have taken the initiative, and this will definitely initiate some sort of awareness or change in our other members, and which will be later passed on to our patients. Research and evidence generation, definitely. These are the cornerstones of India programs and policy initiatives, and it serves as a reliable source of data to the media organizations, academicians, and government on family planning and sexual reproductive health issues.